Welcome to members of our board to our board meeting held in public this morning, but also, as ever, a very warm welcome to members of the public and staff who I know do join and watch in on these meetings. It's really good to have you here. Thank you. The meeting is live streamed and a recording of the meeting will be placed on our YouTube channel. We do have the feature of live subtitles and they can be accessed by clicking on the screen. Please could people mute their mic if not speaking? I think speakers are already aware that you should assume the papers have been read and only highlight key points, please. We'll take questions after your introductions of the report. We continue to attempt to avoid acronyms, although I must say I've seen a few creeping in recently, so let's keep trying on that. We don't have any fire alarms planned, so if the alarm does sign, we should go out the building and gather in the car park. Members of the public, please, if you have any questions, please raise them using the question and answer function on MS Teams, and they'll be reviewed by our company secretary as per our protocol. Questions will be asked at item 21, and there is a maximum of 15 minutes for that item. Our company secretary will ask on your behalf, and then we will seek a response from a relevant director. This is rather a long meeting today, I'm sorry. It will conclude around 2:30 with a 30-minute break at around 12:05, after item 12.3, our premises assurance model. I don't have any apologies for absence today from members of the board and from a member who is usually in attendance, Aled Jones, one of our associate non-execs, does offer his apologies. Kelvin Hepperson, our Chief Information Officer, will join the meeting at approximately 11 o'clock. And we do have a number of colleagues attending for timed business today, so we've got even more of an incentive to try to get our timing right. Have I any declarations of interest from members of the board? No, I've got shaking heads online too, thank you. And looking at the previous minutes of our meeting, are there any matters that you need to raise or change on that set of minutes? No, thank you. And then are there any matters arising and questions about, very well annotated action log, thank you, really helpful. Really nice to see some of the actions in 24, 25, 20 around support to people and stress management is actually, I think, taking effect. So really good to see that. Anybody want to raise anything? No? In which case we will accept as closed those items proposed complete on your agenda. Thank you. And I think that then brings us to our board story. So if I could invite Kim, but also please could I welcome Megan Pitts, our practice educator, who's joining the meeting for this item. So over to you, Kim. Thank you.
Thank you, Chair. So today is the last one in our series. We've heard communication across all three sites within our organisation is always challenging, with a very plethora of different groups coming through. So today I'm really delighted. I see Megan Pitts has now joined us. We're going to have a look at the carers room that's based on St Mawes, which is one of our very busy acute surgical units. And Megan is the practice educator there that took one of a story forward, which I won't spoil for the moment. Next slide, please. Pete, thank you. So we're going to hear a recording of a feedback from a young carer who would have benefited from a space away from the ward, and then go into a YouTube story on what Megan took forward. So over to you, please, Pete.
I was a young carer once, although I don't think I realised it at the time. 19 years old, you love your mum. Of course you're going to look after her no matter what. I remember sitting for hours holding hands on a ward, hearing noises, machinery, feeling the heat, waiting for an update, and I remember the moment it came. We found something else. We had to sit on that ward and be as strong as possible for my mum. I remember she went to surgery as an emergency case that night. Me and my dad waited on the top floor of Trelawney to see if she'd come out of surgery and see if we could get an update. We were both so worried and so scared. If only we'd had somewhere just to sit and share tears and talk to each other, take in what was happening. That would have been everything for us. Somewhere where we didn't have to keep moving out of the way of trolleys and people and making eye contact with whoever was walking past. Somewhere just to be quiet. Somewhere to speak to our family so that they all knew what was going on. Somewhere to detach from the situation so when we went home, we could just be us. Having that safe space would have been everything to us.
Next slide, please, Pete. If you could play the video, thank you.
Hello, my name's Megan and I'm practice educator for general surgery. We do, unfortunately, on a daily basis, have quite a few unwell patients who have diagnosis which isn't great. We do have very poorly patients within our area, and pulling a curtain around isn't always adequate, is it? You can't really keep dignity and privacy for your patients just with a curtain. So we have never really had an area to be able to take patients and their families away from the ward, to be able to properly speak to them, talk to them in a dignified manner that they deserve. So when ideas for this room came about, we just thought, okay, well, why don't we make it part of it a quiet room, so that we've got an area to be able to properly speak to these families and speak to these patients, and have an area which gives them time and space away from that busy ward environment, just to give them a bit of privacy that they need. And as well, we it's quite a stressful environment to work in. Sometimes staff need a little break just to kind of get away from the busy ward environment, take 5 minutes to themselves, take a breather, recollect themselves. So it gives them that space as well. So this room, it was actually a storage room to begin with. So it was just full of shelves. It's seen quite a few phases, this room, and it's not really had much of a purpose. So absolutely. So we had the charities were involved. They were brilliant, and they supplied all of the kind of artwork and funding for things like the decoration in here, the blinds, things like that. We also, of course, we had like estates, and the ward clerk down on St Maur's, she's been fabulous. Jins, she's helped me a lot with ordering, organising. She's given lots of ideas as well. Yeah, but I think, and the ward managers, they've all chipped in, given their ideas. We're all going to be using the room, so I've had emails from different people saying, oh, this would be a good idea. So we've all kind of pulled in together to make it what it is. We've had quite a few families come in and use the room, particularly carers of patients when they need just 5 minutes out. We, part of the room, we supply these carers packs, which are made up of all the information for carers for patients in the hospital. So they can literally just come here, grab a pack, take a seat and sit down for 5 minutes and just have a read through, or take the time they need out of their role as a carer while we're looking after their relative or their loved one. On this board, there's quite a lot of information, and it's basically a support board. There's so much information up here for both patients and staff, which I think is so important to help support them.
Thank you. Thank you for attending today, Megan. I didn't know if there's anything you'd like to add before we open up to the floor for questions.
I was basically, thank you so much for having me. I was just going to give a brief introduction of who I am and just say kind of what led to the room. So I've worked at the Royal Cornwall Hospital now for 8 years within general surgery, and I've gone from beginning as a staff nurse to a deputy sister to now a clinical practice educator. And throughout my career at Royal Cornwall Hospital and beforehand, the topic of effective communication has always been very important to me, and that's really what led to the carers room. I've been a healthcare professional since I was 18. I've been a patient myself. I've been a relative of a patient, and I've been a carer myself as well. And no matter what responsibility I've been in, I've experienced effective communication and poor communication. I've received bad news, I've received uncomfortable news, and I've received confidential information which hasn't always been confidential behind our soundproof curtains. And to me, communication is probably the most important professional and ethical nursing trait. In our busy working environments, when it comes to communication and breaking bad news, do we always keep our trust values in mind, respect and compassion? The NMC states all nurses must use excellent communication and interpersonal skills. Their communications must always be safe, effective, compassionate and respectful. And it's an essential element of building trust and comfort in nursing. And it's the basis of the nurse-patient relationship. It's linked to improved quality of care, patient satisfaction, and leads to positive health outcomes. Part of my role as a practice educator within general surgery is governance. I do answer complaints, and most complaints that do come through me are linked to failed communication. And again, like I mentioned, I was a carer, and it was one of the hardest jobs I've ever done. You don't really get a break mentally or physically. And as healthcare professionals, we need to recognise the work of our carers. We need to support them so they can support us in caring for their loved ones. And it's so important that they feel valued. It's essential for us to provide holistic nursing care. And really, that's what the room is for. It's for communication, respect, dignity, and a little bit of peace.
Thank you, Megan, and thank you for being so courageous to share your lived experience. So thank you, Maury.
Yeah, thank you so much, Megan. That was very, very interesting video, but what you've just said is just really helpful. Just reminds us of how important these things are and what I know you and everybody else does every day to make this happen. Great idea. Really lovely to hear about. And like you, and I'm sure lots of other people watching, we've all been in those shoes, haven't we? We've all had some of those experiences, as you say, some better than others. So what a really important initiative it is. I'm sure I've got colleagues who would like to raise a question or make a comment. Richard, you're first.
Thank you very much, both to Kim and Megan. I was just taken by the conversation on young carers at the beginning because, so many young carers struggle with the emotional and practical demands. And there was a quote about opportunity to be themselves and be not a carer, but an individual. So I just wanted to hear more about that and whether carers get an opportunity to support each other and establish support networks between themselves at all.
Thanks, Richard. I'm sure Megan can come back on that, but others may want to. Megan.
Absolutely. I know there is a support network within Cornwall. I actually received Young Carer of the Year award back in 2008, and it made me feel very valued receiving that award, and I met a network of people through that, which really helped me in my journey as a young carer. But I definitely think when our loved ones come into hospital, we almost feel a little bit powerless sometimes, because from going from being in control and and looking after our family members ourselves, we don't have that control when our loved ones come into hospital, and it's taken off of our hands, and it can feel quite bizarre sometimes. Even if you're not a carer, you may just know someone that's in the hospital. You can feel that way, and in the room on the board there is support for young carers, family members, just to help support them, and it gives an area for communication, and just for them to be able to sit down and take a moment and talk to whoever's looking after their loved one.
Thanks, Kim. I'm going to bring Kim in a moment, Megan, but I think it's really important, given we have got members of the public listening to us, that we know that there is that opportunity to be involved, and to perhaps Kim could pick up that point of how people would access that sort of help.
Absolutely. So on the council website, the local authority website, on our own website, we have a county-wide board for young carers. We also have it for adult carers, but most importantly, a young carer sits on the adults board as well. So there's the entire network with links to, as Megan says, a plethora of clubs, and it takes you through there. Inside the trust as well, we have the integrated safeguarding services, which carers is part of that. We have the carers passports, we have the This Is Me, coming into hospital, all of those link in that triangle that we've seen demonstrated over previous board stories. And most recently, we've started Carers Corner, which is across RCHT and CFT, and they go to different, so it's not always at RCHT, could be at St Michael's, could be at West Cornwall, could be at Liskeard, could be at Stratton, where staff or anyone coming through that day can go and speak to someone and share, and they're then again signposted. So there's quite a comprehensive service, but it's something that, as Megan says, we have to communicate all the time so people remain aware and those links remain updated.
That's really helpful, thank you. Did you want to say something different, Kim?
No, I was just coming in on there. Thank you.
Okay, so I've got Alison first and then Ella.
Yeah, so I just wanted to say thank you very much, Megan. You are quite an inspiration. Hearing your story from carer to in terms of your nursing career as well, but also for highlighting the real importance of communication, also highlighting our trust values and how the two things sit together, and also for highlighting the work that charities do. So for any other staff, watching this today, I think your idea of taking a space that wasn't used and then turning it into something that is really valuable now has been brilliant. So thank you.
And well said. Ella.
Yeah, very similarly, I was going to say the same. What a wonderful use of our trust resources by the team. So to take a space that was underutilised, turn it into such a valuable space, and to do so in partnership with a charity is absolutely brilliant, Megan. And to hear you speak with such passion and such insight was really, really lovely. And to see how you're translating that into your leadership role, I can't commend you enough. It was really lovely to hear.
Thank you very much, Ella. Ian.
Yeah, so thank you, and echo everything that's been said, Megan. So thank you for your presentation. Mine's not a question for you, Megan. It's more of a challenge for us as a board. So we've got a significant building programme going on across the organisation, particularly here at Trelisk. And I think just from a space utilisation perspective, it's really important that these spaces are given a high level of importance. When we're looking at what is a difficult kind of juggling act to get where we want to in future years in terms of the exciting developments, but maintain crucial spaces for staff and patients and carers. So it's probably just something about, do we think we've got that appropriate level of assurance in terms of our space utilisation approach, that these areas are getting the level of importance that we'd all want them to have?
And Brian is away, but we've got one of his colleagues coming later today, and it really is something to be mindful of for all of us as we walk around the trust. We do have fresh eyes on the site in the way that perhaps people are working in the corridors and the rooms don't. So if we do see spaces, I think you're absolutely right, Ian. Well worth bringing them to our attention. Yeah, thank you. Kim again.
I think it's something we need to keep in the forefront of our minds, Ian. So we know before this we used a storeroom on an outpatients unit that's now the express for our staff to express their milk when they come back from maternity leave, and that came about, as we know, from a young junior doctor returning from work and raising, and we went round and had a look. But I do think you're right. As we move ahead, are we keeping that in the forefront of our mind so we don't have to keep changing storerooms, so to speak, into very, very good spaces to use? So I can pick that up with Brian when he's back from annual leave.
Thank you. That'd be really helpful, Kim. We could have a hidden spaces hunt and see how many we can all find. Okay, thanks. Alistair.
Yeah, so mine was just a sort of follow on from Ian. Really nice presentation, really good use of space, which was underutilised. And I think it's important that we don't lose those spaces. But the question is, are there other spaces like that around the trust that we are currently not using or are underutilised, that we could spread the word and use them? Because there are so many wards, so many areas of the hospital where this would be really important. And I think it's under thought of, if that's a terrible language, but it's it's a really important part of people's staff well-being, patient well-being, carer well-being, to be able to get that quiet space just to have to yourself. So I'd challenge us also to go around, and while we're doing our space utilisation work, are there other underutilised spaces we could use for something similar? So, thank you.
Thank you, Alistair. And while you're speaking, I think, and are there other facilities for visitors stroke carers that we should be thinking of expanding? So, for instance, if you are sitting with somebody and don't want to leave them, what's the access to the toilets like? What's the access to drinking water and so on? And in some areas of our trust, it's very good. In other areas, it's really not. So I think, and I know that would be a more expensive venture, but nevertheless, it's really important for people's health. Isabel.
Yeah, thank you. I just echo what everybody else has said, really, but I did want to come back to just highlighting the creativity and inspiration from Megan, because these are individuals that we really, really value within the organisation, and no idea is a stupid idea. So the more we can encourage creative people like Megan to step forward and share their ideas with us, the better. So just really, she's a shining example, isn't she? And we should be congratulating her and saying well done.
So we absolutely do, Megan. Complete congratulations for us and well done. And I'm very pleased to hear that you won the Young Carer of the Year award. I'm sure that was amazingly well deserved, and your people you cared for must have been very proud. So thank you for sharing your ability with us and making lives better for people here.
Thank you so much for having me.
Okay, you set our board off on a very good foot this morning. Thank you very much. As ever, I do say to people, you're very welcome to stay, but I'm sure you've got far more important things to do. But you're very, very welcome to have come this morning, and thank you for your work. Thank you, Kim, too, for bringing that story. Just for a reminder for perhaps members of the public, we always do start our boards with a patient or a staff story, because it just reminds us of why we're here and what we're here to do. And it's exactly people like you, Megan, and the people whom you care for that we're here for too. So really great start to our board. So we're asked to note that report and move on to my report, which you have in front of you. I shan't go over it. I have a tiny couple of amendments, so my apologies for that. Richard Cramer, whom we welcomed a couple of board meetings ago, is going to be serving on those committees as reported, other than as the incoming Freedom to Speak Up non-executive. He will be joining the People and Culture Committee, as well as charitable funds, not the Quality Assurance Committee. So my apologies for that, but that's the other change there. Are there any questions? No? Perhaps then the only thing to add is that we did interview last week some candidates for the remaining non-executive vacancy, and we have recommended somebody to the region, and so we expect them to be joining soon, which will be really nice, because we feel as if we've been sort of down a bit for a while. So really nice to welcome somebody else new. And the balance will tip in favour of the newer people against the older people, which will be a really good thing. Really, really good thing. Okay, anything else? No? Okay, thank you then. Could we receive and note my report, note the actions being undertaken, receive and note my report and approve those appointments of Adrian Davis and Richard Cramer. Thank you. That brings us then to Steve, Chief Executive's report, please.
Yeah, thank you, Mary. I'll take the report as read. There's quite a lot of information in the report in this set of board papers, but I did want to draw board's attention particularly to item 2 in my report, maintaining focus and oversight on quality and care and experience in pressurised services. That sets out a summary of the guidance that was issued by NHS England to all integrated care boards and all NHS trusts in June this year, following a media programme and a number of other matters. And it sets out, as you'll see in the report, a number of areas, 6 action areas for all provider organisation boards to consider, review and assure themselves that appropriate mechanisms are in place. So they include, for example, ensuring the implementation of all of the actions set out in NHS England's Urgent and Emergency Care Recovery Plan letter from earlier this year, ensuring that the CQC fundamental standards of care are in place, and ensuring regular non-executive director safety walkabouts are in place, and there are a number of other actions that are set out in the report. So the report provides back to board the evidence of the assurance against those areas. And I think that's important for any NHS organisation. Clearly, it's particularly important for us, given the level of operational pressure that we have been experiencing and we continue to experience. That's a bit of feedback from...
Yeah. Is everybody off?
Okay. So that's particularly important for us, given the level of operational pressure that we have been experiencing during this year, and that continues right now. We're currently in a very pressurised operational environment today, so it'd be particularly important for board to be assured on the actions that are set out in that particular section. There's a brief update on pay awards. Colleagues will be aware that NHS England have now announced and formalised the pay awards for this year. And that includes for Agenda for Change staff a pay award of 5.5%. It's our understanding that that is likely to be implemented in the October pay this year. That's a national position, and we're just awaiting for clarification and direction from NHS England on the payment of that. Those pay awards will be backdated to the 1st of April, so at whatever point they are paid, staff will receive that on a backdated basis through to the 1st of April. You'll also see in the report there is the anti-bribery statement, and that's one of the action items that board are asked to consider, and to consider giving approval for that to form the basis of our organisation's anti-bribery statement. I did also want to give an update, though, verbally, that as board members are aware, Royal Cornwall Hospital's board met with non-executive directors and executive directors of our integrated care board earlier this week in a board-to-board meeting, and that was requested on the basis of our ICB colleagues requesting assurance on our financial recovery actions for this year and asking for assurance on some of our performance improvement actions, particularly around urgent and emergency care. I think that was a useful meeting, and it's our expectation there'll be a further board-to-board over the course of the next 3 or 4 weeks to provide a further update on both of those areas. There is clearly information in the board about our financial position, but I just wanted to also note that since board papers have been issued, we've taken some further actions in respect of financial recovery to ensure that we can deliver our required financial break-even position this year. And as board members are aware, that's included a further strengthening of some of our workforce controls, including, for example, a temporary vacancy pause, as part of our range of measures to help manage and bring our organisation into a financial position. In that vacancy pause, of course, there are exceptional mechanisms for individual posts to be considered where they are safety critical to the organisation and there aren't any mitigation options or aspects. But like all parts of the NHS, it's a very challenging financial and demand environment for us. And that's an example of the range of actions that have been taken to help to manage the financial position. Happy to take any questions around the papers.
Thank you very much indeed, Steve. Indeed, again, a very full report. And I do find your method of reporting or all the things that are going on around us, as well as what we're dealing with. Very, very helpful. So, colleagues, are there any questions for Steve? Yep. Rob.
It's not a question for Steve, just a quick bit of clarity. On top of page 12, when Steve talks about the 10 executive actions, just a formatting bit, action number 9, where it says action complete, means action 8 was complete, and therefore those that are listed as 10 and 11 are actually actions 9 and 10, so there were 10 actions total.
That's really helpful update. I missed that. Thank you. Richard Cramer.
Thank you. I've got a couple of questions on 2 different areas, so if that's okay, and I'll be as brief as possible. I just wanted to note the solidarity events that took place, because it showed there were very much active listening events, and huge appreciation to Steve for holding them. My 2 questions on those was that attending those, I think there are some challenges around lack of understanding and appreciation of different cultures, although I think it's one of lack of understanding than lack of respect, which is really important. I just want to know what additional support we're providing to managers so they have the skills and confidence to embed a more ethnically diverse workforce, and whether there might be some culture workshops to help facilitate open discussions about cultural differences. And also there was a question around raising concerns where there are cases of racism. And there was an interesting discussion on that. And I just wanted to know if that we're clear what staff should do in those circumstances. So there were questions on that. And then I did have another topic as well.
You stop there and then come on to the next topic. Steve, do you want to?
Yeah, thank you. Really important questions. Thank you for that, Richard. Just to comment firstly that following the solidarity events, listening events with colleagues from across Royal Cornwall Hospitals and Cornwall Partnerships NHS Foundation Trust, having now done 3 of those events, our next step is to meet with our staff network colleagues in CFT and RCHT to move from the listening and hearing into what are those next steps and actions that we might take. We had some very strong guidance from colleagues across our 2 organisations to say, please don't leap to solutions, please don't leap to actions, but listen, hear, understand, give space for people to share their experience, and it's been really valuable to do that. So in terms of moving forward, that will follow after that further engagement with our staff network colleagues. That said, a number of things, as you've indicated, came up during the listening events that could be more urgent steps, and one of which is the communication and reminding staff across our organisation and across CFT the ways in which concerns can be raised, and there are a range of ways where they can be raised openly, immediately with managers, with colleagues through formal online reporting, or colleagues reaching out to any executive directors or to myself. And there's a range of mechanisms where that can be done. And there are also mechanisms where colleagues can raise concerns confidentially if they don't feel safe and supported to raise those openly. So those measures and arrangements can include or freedom to speak up mechanisms as well as other routes as well. And we have communicated and reminded staff across our organisation those different routes and mechanisms to raise concerns. I might ask Alison if there's anything you'd want to add, Alison, on that question around support to managers. I know that forms part of our ongoing work with our staff networks, but if there's anything you want to add, fine.
Steve, in terms of the areas that I was going to highlight. We do talk about this later on in the board as well, when we look at our workforce equality standards too, and the amount of staff from ethnic minority backgrounds that are reporting through either to HR or freedom to speak up. And I think, Steve, you mentioned about the role of the line manager, which is hugely important in this, because as we heard on those solidarity events, there are a number of issues that colleagues are facing. You touched on cultural competence as well, Richard, and it is something, well, Steve said we're not rushing to solutions because we want to speak first with our networks, but it is something that the two HR teams across both trusts are now thinking about in terms of what can we do with our OD plan to try and support the organisation on cultural competence. Thank you.
Alison, was that also the point that you wanted to raise?
Yes, it was. Thank you.
Thank you very much. Isabel, you're next.
Thank you. I just wanted to go back to the part of Steve's report. We were talking about oversight on care and experience in pressurised services, which I think I just wanted to share. It wasn't a question, but just a comment that this morning I was really lucky to be able to attend the site meeting, the 8 o'clock site meeting with Robin. And what impressed me enormously was in getting to the site meeting, he also walked me through the emergency department, and having seen the number of ambulances outside and recognising the pressure that everybody is under, what struck me immediately was the level of calm and professionalism within the department everywhere I looked and everybody I spoke to. And the site meeting was just extraordinary, both in terms of the data that's available now. We're going back years, of course, we weren't able to have the dashboards and all the information available, but also that it just struck me how cohesive that meeting was in terms of everybody fulfilling their part in attending to the patient safety and quality first, and making sure that every decision they took had that at the forefront. So I wanted to just note that because it was so impressive, given the very great pressure that we're under at the moment.
Really helpful. Thank you for that feedback. And those meetings are really important daily and several times a day. Events at 7:45 in the emergency department, a meeting to immediately identify patients who can be moved from the emergency department into our acute medical units, into our discharge lounge, or same-day emergency care or other facilities, followed by that meeting with colleagues from across the whole organisation to drive flow. And certainly we see colleagues working incredibly hard every single day to manage a very challenging situation. And we have equivalent mechanisms with our system partners to look to ensure that we have the same level of pace, determination and actions across the whole of our organisation, across the whole of our system to support flow. So really helpful that you were able to see part of that this morning.
Thanks very much, Steve and Isabel. Richard, I am going to come back to you, but I have got a few other speakers, so I'll ask Adrian next, please.
Thank you. Mine's not a question, it's an offer. Item 4, emergency preparedness, resilience and response. In my fire service career, I was a CBRN Gold Commander, hazardous materials advisor and member of the LRF. So whoever is organising those exercises, I'm available to help. I'd be more than happy to do so.
Really helpful, Adrian. Thank you.
Thank you very much. Usma.
I need to chat. No, works fine. I wanted to follow on from the Isabel's comments on the flow and the section on flow out of the hospital, supporting flow out of ED, and your points on the home care team and the virtual wards. I just wanted to get a bit more information on the capacity of those teams and how they're working. Is it still at a? I did a walk around with Alistair a few months ago, and actually we managed to speak to one of the sisters that was dealing with the virtual wards, and it seemed to be going really well, and they were expanding from ward to ward. So really just to hear a bit more about how that's going, and is that service being communicated to patients and carers? And if not, is that something that we're ready to share?
Yeah, really important service areas. So our virtual ward teams and capability across Royal Cornwall Hospitals and Cornwall Partnerships NHS Foundation Trust continues to have capacity available. So there is more capacity to increase the number of patients who are able to use our virtual wards. In terms of the amount of use of virtual wards, we compare and benchmark very well within the Southwest region. But clearly there's more opportunity for that. There's been significant success recently in using the virtual ward as a step-up facility. So I guess by that I mean using it as an alternative to ED attendance and hospital admissions, so really important. But more work for us to do, I think, to be able to maximise the available capacity on stepping down an earlier discharge from hospital. There are other important capacity areas across the system as well. So another major one is our frailty same-day emergency care services. And at Bodmin Hospital and now at West Cornwall Hospital, there are frailty same-day emergency care facilities to provide an option for patients who may need some form of urgent assessment and support, but don't necessarily need to be in an emergency department or an acute hospital. The Bodmin Frailty SDEC was opened earlier on this year, and the West Cornwall Hospital Frailty SDEC was opened about 6 weeks ago. They both have been operating, but again, they both have further capacity that could be used. So there are programs of work underway currently to identify opportunities to increase the use of our virtual ward capacity down and to increase the use of our two frailty same-day emergency care services. I'm not sure if Alistair would want to add anything on either of those points.
Yeah, no, I think that's. I think you've described that well, Steve. I think it's the coordination of those services, I think, which is really important. And there's a lot of work going on at the moment with Juliet Ferris, who is the SRO for frailty across the system, looking at how we communicate to all of our system, including our patients, what the offer is going to be in the community moving forward. So I think our system have agreed that our strategy will be to assess the frail elderly patients, of which we have a higher percentage in the rest of the country, in their own homes or as close to home as possible, and then be able to manage them in the right place first time. And the availability of the frailty SDECs, the availability of virtual wards, the availability of our community diagnostic centres, which are co-localised with these services, are all important aspects of managing people as close to home as possible. So the direction of travel for our system is really clear. And as a result of doing that, we will keep as RCHT managing only the people that RCHT really need to see, the really sick, the patients who've had heart attacks and strokes, who need intervention and surgery. So, yeah.
I know that the question, if I just add, whilst the question was around virtual wards and frailty same-day, or I comment on frailty same-day emergency care, we are operationally challenged with a number of patients in our hospital who are waiting some form of onward other care. Now that might be patients waiting to go home with some form of community care, or waiting for nursing residential reablement or other forms of long-term care. And as an example, as of our latest position yesterday, there are 100 patients in Royal Cornwall Hospital beds that are in that position of waiting for those forms of onward care. That is a deteriorating position. So that's one of our priorities and one of our whole system priorities, to find mechanisms to enable those patients who no longer need to be in an acute hospital to be able to move into a much more appropriate setting, either at home with domiciliary or other community care, or into whatever their long-term form of care would be. But noting that has been a deteriorating position, that is urgent and critical for us to be able to address as well.
So a point about rising readmission rates. Is there a mechanism to use any of these virtual wards to avoid those readmissions? Is there like a way in?
There are a number of ways to access into virtual wards, so that they have been designed to be as accessible as possible. So certainly that there are opportunities for the virtual ward to support a reduction in admissions and potentially a reduction in readmissions. The emergency readmission rate is one of our IPR metrics, so we have close oversight of that, and I think Alistair wanted to comment on that.
Yeah, so my only other comment was that obviously the virtual ward is a CFT run organisation supported by our clinicians. CFT virtual ward team are in our emergency department every day. They're also on our admission wards every day, so they can, if there's somebody readmitted who's appropriate for the virtual ward, they can transfer people out onto the virtual ward. So we're working very closely with these community teams, and they're often in the hospital, wandering around our wards, speaking to our clinicians, finding out if we can step down patients into the virtual ward so we can get them home quicker.
Alistair, could I just add to that? So, given the situation that we all know about, how come there are sort of space in those facilities?
That's a very good question. So when the virtual wards were originally set up, they were set up in COVID to look after COVID and COVID oximetry, so the measurement of oxygen levels. And then their use expanded to acute respiratory infections. So usually frail elderly or people with comorbidities who have a single problem, like a chest infection, who could be managed at home. And that was the national setup of those. As we've moved forward, the capacity has grown, and the numbers of people who are suitable for those particular pathways have almost been saturated. So we're having to expand the team's knowledge and experience to be able to manage heart failure at home and manage other conditions at home as well. And I think in Steve's outline, he talks about the work that's going on at the moment to manage some end-of-life care through the frailty ward, and also more of the heart failure work through the frailty ward. And one of our heart failure clinical nurse specialists has moved across to the virtual ward team and is helping to set that up.
It's really helpful, Alistair, thank you. I know Richard, yours was on this topic.
Yeah, it very much builds on Usma's point, and it's around health inequalities and the assurances, the extent to which different groups at risk of exclusion, whether it's ethnicity, disability, deprivation, are being able to access virtual wards. So I'm thinking about people with different communication needs, or where there's a need for clinical judgment, where people may have comorbidities, maybe severe mental health illness or learning disabilities, just to make sure that we are meeting everyone's needs.
Jim, did you want to come back on?
So it's predominantly a nurse-led service. So having an integrated safeguarding team absolutely links in with that, Richard. I think as Alistair says, now it's saturated with, we have gone wider. So we use the learning disabilities passports, for example. Everyone's aware of those. Some of our acute nurse specialists have moved across over to be able to give that expertise. End of life starts, I believe, next week. That's linked with both the system, CFT and RCHT's end of life system. So as it expands, so do the connections within. Even with the integrated infection prevention and control, everyone can link in with everyone to make sure that those personalised needs are met, especially when there's a vulnerability.
Thank you very much. I've still got two more speakers, so I'd be grateful if we didn't have any more than that on this item. I've got Adam and then Adrian. No, Adam, then Ian. Apologies.
Thank you. I've got two questions, please, on the 10 executive-led work streams, which is across page 48 and 49. First question, Mary mentioned at the beginning about abbreviations, so please forgive me. There's a number of points here where I have no idea what the abbreviations stand for. If someone could just explain, please, particularly on 10 executive-led work streams 1, 3, 4 and 6. Number 1, what does GIM stand for? I'm sure I should know.
General Internal Medicine.
Thank you. Number 3, what does SDMA stand for?
Same Day Medical Assessment Unit.
Thank you. Number 4, what does SHOP and CLD stand for?
CLD criteria-led discharge, and SHOP is the mechanism, the order in which you should do your ward round. So the sick patients, the home today, the other patients, and then plans.
Thank you. And 6, what does PDD stand for?
Mandate of discharge.
Thank you. And then on item 11, which is now item 10, as explained by Robin earlier, agree the red line actions. Can someone just briefly say, what does that mean?
So we've defined 4 elements that we're calling our red lines. I won't say what they are yet because we haven't finalised our exact actions we take with them, and I can brief you offline, Adam. They are essentially us saying these 4 things. When we've set the descriptions behind them, we won't pass those, and we will have additional actions that we will take to not exceed those red lines. So other trusts have implemented something similar where they define these are the things that we will not pass to ensure that we get the flow for our hospital. So that action's about properly defining those and the subsequent actions that we'll take to make sure those red lines aren't passed.
Thank you, Robin and Alistair.
Sorry, it's Ian. Thank you.
Thank you. Yeah, so again, on the same topic of the pressurised services, Steve, I wasn't clear from the paper. What's our plan in terms of our continued assurance on this, recognising, as you said, that we operate in a pressurised way for a significant proportion of our year, and of course we'll be heading into winter soon. So it was just to understand what your thoughts were in terms of how board gets that assurance of, because these 6 questions need to be asked regularly, don't they? So it's just to understand that, if I may.
Yeah, that's a really important question, particularly in the context of going into winter. Kim, just looking to you for your thoughts and guidance around that as to whether the set of actions and questions in here would lend themselves to some form of regular reporting to the board, or whether they're already reported through different routes.
And we had that discussion yesterday when we were following ELT. So this is our first tranche. Each part gets picked up in a different, but I do think it will have to be a quarterly report that comes back through ELT and forms part of Steve's CEO report, because already I know there's been changes and quite right, the actions evolved and others closed down. So we will definitely look at a quarterly mechanism through ELT and QUAC, but form part of the board update.
Thank you. Robin, did you want to come back in, or was that a legacy?
Can I just say, I popped in the chat, but page 334 of your packs have the readmission rates. We generally track the standard of 7%. Last 2 months, we've been slightly above that at 7.49%, but we're under our upper control limit. So we're within the range, Usma, that we would expect to be from a readmission rate.
Really helpful, thank you. Does that conclude the questions for Steve? Thank you, Steve. Again, a really useful discussion this morning. So what we're asked is to receive and note your report, to note the actions being undertaken to ensure we maintain focus and oversight on the quality of care and experience in these pressured services. And we're asked also to approve the anti-bribery statement, which was attached to the report. So if you could indicate your approval, please, that would be helpful. Item 8 is a starred item. Starred items are those which we bring to the board for information, and we request that if there are questions there, notice to me beforehand. I haven't received any questions, and so this report was due to be received in July, but was delayed because of the pre-election guidance. And so here we're asked to note the report, the achievements rising from the Trust strategy to date, particularly the journey of improvement progress reports, which are on pages 10 to 12, but also note the delays reported this quarter relating to e-care, relocation of the cardiac department, and our university hospital status application timeline. So if colleagues could note those things, please. We will move on to the safe high quality care section, where we are taking the committee reports, and chairs are kindly going to present your reports. So what we've done in recent months is we've been moving through various stages of getting the governance really good. at the board, asking chairs to bring their assurance or otherwise reports. What I would like to move on to today, to see how well it works, is that if in the other reports, as they're presented by directors as briefly as possible, unless there have been changes since the committee, I would be grateful, Isabel and other chairs, if you could field those questions, as it were, and if you feel there's been a rigorous debate, could you say so? Otherwise, let's take the question and let's see how that goes. Okay? Thanks very much. So, over to you.
Try that out. I think I'm going to keep this really brief because there's a 25-page report providing the various levels of assurance regarding the work that the Quality and Safety Committee undertake. And as you can see from the number of items heading under safe high quality care, there's a huge amount of work that is covered by the committee, and that is detailed within the report that you have. So I won't go through the report, you'll be pleased to hear, but I do want to just make a few points to notify the board about. The first is really a recognition that at the moment we have particular challenges in terms of the capacity of the Chief Medical Officer's office and the associated functions with that, and that's partly due to vacancies but also particular issues around sickness as well, so it's for us to just be mindful of. I think the second point that I wanted to make is noted on the front of the report around the need to escalate the issues around supporting workforce for end-of-life care. And I think I would extend that also to include other areas of service that are coming under increasing pressure. And in particular, I know Kim has mentioned several times already this morning about the integrated safeguarding service and the pressures that they're facing to deal with rising demand and shortfall in staffing to support that. I think that with both those cases, and there will be others as well, we do need to note the financial pressure on our organisation. And so at the moment, the challenge is how we meet those shortfalls in a safe way to ensure our patients are getting the best possible service that we can, given the resource constraints that we face. But I wanted to flag those two particular services, end of life and integrated safeguarding. I think the final point I would make, which doesn't appear in the report, but it's just really so board members and our public are aware that there's an enormous amount of work going on more widely across the system in looking at quality priorities that both we judge to be important, as well as our partners in Cornwall Partnership Trust, and also across the wider system. And at the moment, there's some work now going on to align our thinking around those priorities so that when the system is reporting on its quality and safety measures, we are doing our part within our organisation to make sure that we're giving due regard to those items that are of importance to the wider system, whilst recognising our own statutory obligations as an organisation to cover the items that we do need to cover, most of which you'll see in the papers that follow my preamble. So I think I'll stop there unless there are any questions specific to the assurance report. I think I'll leave it there, Mary. Thank you.
Thank you very much indeed. Kim.
Thank you, Isabel. The only thing I would add is we had a really good, I think it is on page 75. The overdue incidents are sitting at 737. We've had this conversation before about do we benchmark? It's really difficult. All trusts have overdue incidents, but it's really important to note that there is a recovery plan against those, 15 of which are moderate. There is a framework behind it. It's monthly reported through the Incident Review and Learning Group, and it will still come through QAC until we are assured that we're back on track. But we're confident with the assurance provided by the team that there's a recovery plan in place.
That's really helpful, Kim. Thank you. Preempt one of my questions. So really helpful information there. Thank you. Any other questions for Isabel? No? Okay, thank you. Oh, beg your pardon, Elizabeth. Getting quickly.
Yes, I just wanted to, on page 89, pick up on the point on safeguarding referrals and sickness. I'm just trying to find the page. Here we go. It's supposed to take me straight there, isn't it? as in the safeguarding report, Q1 report, it says there's been an increase in both sickness absence, which I think will be covered in a later report, but also in safeguarding referrals. And I just wanted to ask if you could clarify that.
I think Kim's probably better placed to answer the detail on it, but what I would say is that we know that that service is under particular pressure at the moment. And the other thing that we've asked for further assurance around and information really is to get a better sense of the breakdown around gender in terms of referrals, so that we can be mindful that if we are seeking assurance that we're providing the best we can, we also need to take into account where those referrals are coming from, both in terms of our health inequalities, but also in terms of targeting support dependent on gender as well. But Kim, you may want to just build on that.
The team have been affected by some quite serious illness, so they're long-term, not short-term illnesses. We've been able to support them through the measure of fixed-term contracts. And part of the support around there is how do you keep those skills within? So whilst they're still maintaining a full service, we're really conscious of the support they required, hence the business case that's gone through, especially with this vulnerable group of individuals in many cases, how we maintain that support. And it isn't just with the referral, it's supporting the staff if they need admission or discharge back out into the community. So it's something we're keeping a close eye on, and I know that's one of the 5 high-risk business cases that are going through the financial process at the moment. Thank you.
Okay, colleagues, thank you very much, Isabel. Let's come on then to 9.1, as briefly as you always are able to be. Kim, please.
As you can see in Isabel's comprehensive report, the only things that I think I would point out is the Euroking deadline, and Euroking is the electronic system that's being rolled out nationally. That will still, on our national database for alerts, still look like we have not met the deadline, which we haven't, but like most trusts we haven't, but you can't change the original deadline, so you will always show up as being non-compliant. We're still in the process of doing the last tweaks, and the deadline, as we all know, has been extended to December 24. I would like to say that the maternity CQC action plan, that is now complete, but we have the improvement plan and others that are still ongoing. The appraisal rate for maternity is now 81%, and that continues to be monitored, which is really great. 2 case notes I'd like to reflect on is the very sad indirect death of one of our maternity parents at 5 weeks postnatal, who passed away at UHP, which is at Plymouth. I think this has been referred to the Maternity and Neonatal Safety Incident Board, and we think one of the learning that will come out of that is how do we improve the communication between the genetic service, who then informs the GP, who could then inform our maternity services. So we're just having a look at that because we think that will be one of the early learnings in this very sad case. And the case of the neonatal death, I think when you read it, you could question, had we tested the mother's intellectual capability? That has been done. We did the postnatal care of this case. Mum was already under the care and the supervision of courts and other services, so that would have been covered there. It's just a really tragic incident that I think we just need to note, and we'll continue to be part of that investigation as we move forward, and I'll leave it there.
Super, thank you very much indeed, Kim. That responds to some of my queries. Are there other questions for Kim on this report? Adrian.
Not really a question, just to say that I had the pleasure of accompanying Kim on a walk around the maternity and neonatal, and I was really impressed by what I saw. The staff were absolutely excellent.
Really lovely to hear. Thank you very much, Adrian. Thank you. No, Kim, I think we're then asked to note the continuing Tier 3 compliance requirement challenges, note the completion of the maternity CQC action plan with the fact that we've also now got an improvement plan, and discuss and note the Year 6 position and risk in relation to safety action for compliance. Thank you. If we note that, then on to safer staffing, Kim.
Thank you. So this is a really comprehensive report, and it has been shortened. The full report went to Quality Assurance Committee and is available if anyone would like to see that one. I think the only thing I would raise over and above what is in the report in Isabel's overview is I'd like the board to know that national guidance has been followed with the updated re-education of all staff. So these are nationally mandated tools. There used to be one, and now, as you can see, there are several within those specialties. We did a full review of our education for all staff, because that's part of making sure that that variation doesn't occur. And you can see there's a very stringent check and challenge right from the beginning of the 20-day audit, right the way up through myself, who finally signs it off. So that check and challenge and peer review is really important and drives out those variances. It also includes the model hospital data. It has complaints, incidents, weighted activity and patient care hours per day, which is nationally mandated. I will not go through all of the 16 recommendations. They're comprehensive. They will be followed through, and you'll see those in future monitoring. It's really important to note that there are 6 wards that will need repeats of this in September. So at this moment, we are not asking for any further investment into our staffing, but just to note there is some repeats that need to be done. In the main, they are, for example, Zena unit, which was our escalation ward, and what is the longer term plan for Zena, for example. And for Lowen and Frailty, those are the escalation beds or additional capacity put in that we need to make sure, are they staying, and do we need to relook at funding, and then what does that do to the establishment there? We did, and it's no surprise, following the triangulation of Aspire, which is our ward accreditation and quality safety programme, we took the decision to split trauma unit into trauma 1 and 2, and you'll see that that has had an impact temporarily on the staffing required, and that might need to be considered for the 25-26 round, but it's really important to note. And we've seen subsequent improvement in our quality and safety standards, which are under continued monitoring through that programme. And then just to note, which sits with our maternity report, that we're going to do further work on our neonatal staffing position following the new guidance, and we'll be able to track that through the maternity and neonatal report. And I'll leave it there.
Very much. Again, a really comprehensive report, and you said it had been cut down before we got it, so thank you for that. Colleagues, are there further questions? Ian.
Yeah, thank you. And agree, I hadn't realised it was a shortened version. I think it's a really comprehensive report and really welcome seeing it. So thank you, Kim, for all the work that's gone into it. I just wanted to clarify for board members on some of the elements on page 118 in our packet. Some of the language talks about non-funded, and then it says non-recurrently funded. So most of these areas in terms of our escalation are non-recurrently funded, as opposed to not funded. So just to be clear on that for colleagues. I guess I was struck by how we link this, the good depth of information in this, to our productivity and our financial recovery challenge. So I think it'd be really helpful, Kim, and we can pick that up offline in terms of how we make that, particularly some of the things like where we've invested in areas and using this. One of those that jumped out to me was where it talks about discharge coordinators. So again, not necessarily for now, but I'd really welcome us just getting that assurance on. That was a step change we did in those roles in terms of moving that to a specific role to understand what impact that's had on our level of discharges and whether we think that's had the desired effect and is there any learning from that. So it touched on them as part of the change since the last report, but I didn't get a feel for whether it was a change we thought was being successful or whether it was just a change that we'd enacted, if that makes sense. So not necessarily answering now, but just to flag that. So.
Yeah, so I think, yeah, we can absolutely do that. And this is part of, as well, as we move through, this is the evidence base for quality and safety, which gives us a really good platform for productivity and our financial challenges. Absolutely, we can look at the efficacy of the discharge coordinators. And I think that was the predecessor to that was the meaningful activities coordinators, and how we change the skill mix and the profile of those units, so we can pick that up offline. And I think tremendous thanks goes to Paul Hyton and then Bernie for the absolute rigour, and unfortunately Paul has left us for newer pastures, which is really great in his career, but of course it's that check and challenge which has absolutely driven out that variance, which gives us a really solid baseline against each tool.
That's great. Thank you very much indeed. So I too will not go through the range of management recommendations and actions, but we are asked to note that this current report provides us with a range of data and information, giving assurance to the executive leadership team and to ourselves that the staffing has been safe across the three RCHT sites, the nursing and midwifery staffing. That we need to note for assurance that national guidance on undertaking the review has been followed, has been robust, and we've engaged ward leaders, clinical matrons, head of nursing with the right level of overview and scrutiny by the corporate nursing team. Also to note the inclusion of the national model hospital data in relation to regional and national performance for care hours per patient day and weighted activity unit. To note the current position with the coronary care unit not meeting level 2 staffing ratios, and there are no concerns in relation to the clinical model and safety outcomes. Note the clinical position with the neonatal nurse staffing position and the actions proposed for going forward, and note the current position with the programme of work in relation to allied healthcare professionals across both RCHT and CFT, which will be available for review at the next review period. Also to note the management recommendations and actions. So thank you for that. We can then move on to the volunteer strategy, and I think Bernie is joining us online for that, although we may be a tiny bit early, so maybe she hasn't joined us online.
I see Bernie's here, Chair. Yep, I think if I just open this, it's tremendous thanks to the patient experience group and all of our volunteers that have come forward with this strategy. I think it's really important, and I'm sure Bernie will touch on it, how we take this forward now with the operational mechanisms. But it's truly great to see a inclusive strategy coming forward, and then how we enact that will be reported through patient experience group. So Bernie, I didn't know if you wanted to.
So thanks, Kim. I just wanted to thank Rebecca Cave, Esther Penrose, Verity, Mark, and as you say, all of the volunteers that have kind of contributed to the development of the strategy. It's a 3-year strategy, not a 10-year strategy, because we recognise that there is some further engagement work that we need to do, particularly as we think about volunteers and that wider concept across Cornwall. There are 3 key strategic aims that have been developed. This was through engagement through a survey that was sent out through all of our volunteers, and also we had 2 subsequent engagement events which were just really, really vibrant. I think you can never underestimate the impact that volunteers have, not just on patient experience, but also the impact that they have on staff experience too. And board members will have seen that through our Butterfly volunteer scheme, other volunteers coming to board, but also just some of the simple things, the way they have impact, you know, the role of our friends that they have in terms of our cafes throughout the organisation, and in particular the role that the friends played through COVID-19, where they supported us extensively. So survey, 2 engagement events, really 3 key strategic aims, a programme of work for this year. I think one of the things that we really recognise is our partners are really important, and that partnership element, we know that there is more work that we need to do to strengthen that post-COVID. So we are continuing to do that. We've got some meetings set up in September. This has been, in terms of the engagement process, this has been through the volunteer steering group. We made some final amendments to it last month, just being much clearer about what the role of the volunteer was. So that was the final piece of feedback that we've incorporated into the strategy. And then it's been through patient experience group, where we have Health Watch engagement, ELT, and it was endorsed for approval at QAP.
Really helpful to hear you talk about what a wide range of different groups this strategy covers, and also that the consultation clearly will never end. It's constantly continuing, I know, and involving people. So thank you for that. Other questions, Richard?
Thank you. And part of the disclosure, I sit on the volunteer steering group on behalf of the board, and I really just wanted to applaud both the strategy, but also underpinning that is applaud every volunteer that we have. I'm humbled and inspired on every occasion I meet our volunteers and the work that they do that is so valuable across the trust. And from this strategy particularly, I think it is one of the first attempts I've seen to bring a cohesive strategy together. And I think it's I would like to applaud just the inherent within the strategy is this sense of identity that is coming out, and the ability to strengthen identity for our volunteers as part of our community and part of our partnership within our workforce. The second thing is I'd recommend the board think carefully and closely about how we maximise the benefit of expanding our volunteer base across a geographic location and site, particularly when place is so important to our strategy. And then thirdly, recognise the attempt through the mandatory training to bring a comprehensive and universal understanding of volunteering and skill set to volunteering from a very disparate population of volunteers. So really just want to commend this strategy to the board.
Thank you very much, Richard. I totally echo what you're saying. Super. Alison?
Yeah, first of all, thank you to Bernie for all the leadership on this particular strategy, and again would echo what Richard said in terms of all the amazing work that the volunteers do. I had a question on the measures of success and just wondered if we could be a little bit more ambitious in terms of the numbers of volunteers that we recruit and then pull them through into paid roles and employment within the trust. And that could be both from those volunteers who are more mature, who've already had a career, but also at the younger end, we do have young volunteers who volunteer with us, and whether we could do some tie-up with learning and development and pulling or trying to pull them through into T levels or apprenticeships. So I just wondered whether, Bernie, there was something more on those measures of success to try and set some more ambitious targets. And then on the second point, as part of the board, we were really privileged to attend the 1-year butterfly birthday celebrations earlier this year, and I just wanted to call it out, but I met somebody who had done 40 years volunteering in that birthday celebration, and just how amazing that individual is. I have been sort of talking with our coordinator on the butterflies about whether there's an opportunity to work with my dual hat on in CFT in terms of community hospitals as well, knowing the fantastic work that we've seen happen here for end of life in RCHT. So I just wanted to sort of report on that development. Thank you.
I'm back.
Alison, I totally agree with you on both fronts. So the bit in particular about how we strengthen our young people through volunteering and bring them into careers through NHS is a really well made point, and we'll strengthen that in terms of here and the links with our L&D.
Thank you very much. Ella?
Sorry, on that point, I think, Alison, we might need to, if we can join up, or we're at fear of duplication, we've got the Young Volunteers programme as well, and we've got lots of data how that pulls through. So I know we've got trainee midwives, doctors and others, so I think we can strengthen that. For the end of life, the two groups at the moment are liaising, so we can touch base with our dual hats on.
Thank you very much. Thank you. Ella.
Hi, yeah, I just wanted to support this strategy and just reassure the board that from the perspective of, we've talked before around all our sub-strategies need to align and be developed with this strategic development team. This one absolutely has, and I think it shows through in terms of that alignment and the common threads, particularly around partnerships. I'm just really pleased to see it here in such a fantastic format and with real clarity. So thank you very much to everyone involved.
Richard?
First and foremost, I just want to recognise the unique role of volunteers in terms of their relationship with patients. It's different to a paid role, and there are huge reciprocal benefits. I also picked up from the strategy that we can really enhance our work through volunteers, but only if we improve the experience of volunteers. So they're quick fire questions, Bernadette, so finger on buzzers, I'm afraid. I just wanted to get an understanding of we've got a range of volunteer roles. Are there particular type of roles we're looking to expand? The second bit is, how do we recruit them? Do we have a standardised process? Do we know how many apply? Conversion rates? Any barriers? Do we have clear job descriptions? Do we monitor attrition rates? So I just want to understand the recruitment process for volunteers. And lastly, about, do we have data and insight about our volunteers? And do we use that data insight to inform our work? And do we collect data on protected characteristics in the same way as we do for staff? Thank you.
Great questions.
Really great questions, Richard. So thank you. So yes, we do have a standardised approach for recruitment. Is there more work that we need to do in terms of insights and data? Yes, and that's part of that is part of the work that the volunteer steering group, which we've set up as part of the strategy, will continue to do, because there is more work that we need to do in that particular area that we can then use in terms of continuing to build our volunteer base. And 3, in terms of some of the protected characteristics, we have some of that, but again, there is some new reporting that we're now doing that will feed up through NHS England in terms of the national volunteer piece that we are actively now contributing to, because we haven't had a level of transparency around that before.
Thanks very much, Bernie. Uzma.
Thank you. So Richard has asked my question about protected characteristics and what data we have, but just also, are there, based on the information that we do have we identified whether there's any barriers to those protected groups in wanting to volunteer, knowing how to access it? It's traditionally been or been quite a traditional model, and with the work we're doing in our whole EDI program, it'd be great to see if there's ways of entry for those groups.
Yeah, really super point. Thank you, Uzma. Bernie, did you pick that up?
Yeah, I did. So it's a really good point. There is more that we can do in that area. We do have staff with protected characteristics in our volunteer program and in our patient leader program too, which form part of our volunteer group. But with anything, we need to make sure that those groups that we are inclusive. So definitely more work that we can do.
Thank you, Bernie. And when you say that, have we got the resource to do it, and when will we be getting on with it? I think you've been muted, Bernie.
Yes, sorry, I just unmuted. So yes, we have through Verity, our volunteer services manager, and also our EDI links.
Thank you. Steve, could I bring you in?
Yeah, I really welcome the strategy, Bernie. I think it sets out really clearly our intent, and I'd echo what colleagues have already said about the amazing work of our volunteers. I think we're all humbled by the time that they give and the impact that they have. So my question was around when we look at the partners that we work with, so for example, Friends of Royal Cornwall Hospital and our friends of the hospitals here, there's such a rich legacy of support, fundraising, and a really strong identity. And I just wondered if you could say a little bit about how this strategy supports that existing engagement and support that we have. It looks to me it very much does, but if you could say a little bit more about that, I think that would be really helpful.
Yeah, I think you know, we have a number of partners that we work with, Friends, Macmillan, and others. That kind of branding and identity within that is really important, and we shouldn't lose that. And I think we recognise also the role that we can play in terms of supporting that increased branding and that identity across all of our sites, and with any other new partners that we know that we continue to work with, like say Volunteer Cornwall, for example, in the future. So it is really important, and those partnership meetings are really important too, and that's why we've included partnership working as part of the strategy to make sure that we continue to build on that going forward.
It's really helpful, thank you.
Thank you. I don't think there are any more questions to raise. We're asked to approve the Voluntary Services Strategy 23 to 26, if colleagues would be good enough to approve that. Robin, if you could forgive me, I'm going to move straight on to item 9.5 because Bernie's with us, and Bernie, you're on then, and then I'll come back to your item. So Bernie, would you be kind enough to take the Patient Safety Instant Response Policy, please?
Thank you. This is our completely rewritten Patient Safety Instant Response Policy, previously called Incident Management Policy. It's a statutory policy as part of our overall governance framework. It's been, as board members, some members may be aware, we have moved over to the National Patient Safety Instant Response Framework. So this policy reflects all of the requirements of that. We were an early adopter of that policy, but also some new national standards have been published now. It's been rolled out to all of the NHS. So as the document outlines, it outlines the kind of key changes. The engagement process around this has been with all of our subject matter experts that we have, and also any national guidance, for example, child death review, health and safety processes, etc. All key subject matter experts have been involved. In particular, it looks at the role of how we engage patients and families, which is a key bit around PSERF. So that's reflected through the document. It has been through the Instant Review and Learning Group. It's been through ELT. It was a review at QAC, and actually Alid provided some really helpful feedback there. Sometimes you get a bit word blind to these types of things, and recognising it's a big document, but we just strengthened the section around safety too. So that's been the key change since QAC through to here. We take it as obvious, but we just needed to make it was really helpful to make it a bit more explicit into the document. So QAC's endorsed it. It's here for full sign off, and we are using this operationally day to day. Currently, there's due to be some new, some updated standards published next year, and then we'll make any revisions and bring it back based on anything new that comes out next year.
Very much, Bernie. And as you say, it's had some good discussion. Are there colleagues who want to raise anything on this policy? I don't think so. So thank you. Thanks for being with us, Bernie. We're asked to approve the Patient Safety Instant Response Policy because that is a matter reserved to us as a board. If colleagues would indicate approval, please. I'm going to move rapidly then to 9.4, our health and safety policy.
Thank you, Mary. So there's no material change in this policy, but to bring colleagues up to speed, the policy has been reviewed by the Health and Safety Committee, the Executive Leadership Team and Quality Assurance Committee as per our governance structure. The changes we've made is we've made some updates to the legislation references that have changed. We've put some revised effort into making it clearer people's roles and responsibilities. In particular, we put some work into my roles and responsibilities as the Executive Director accountable for health and safety, and we've made some changes to how we're managing contractors on our site and how those roles and responsibilities work. And then there's some minor
formatting changes through the document. So it's here for approval.
Thank you very much. Are there questions?
Just a question relating to health and safety, not the document. I've seen the document, that's fine. I wondered if we as a board do any refresher or board development on our responsibilities regarding health and safety.
We did a board development session. It's been in the last 12 months. We brought in an organisation called Safety.
You could tell us, I'm sure. Yeah.
The exact date, Lindsay will know because she's.
Yeah, it was last summer. We do a review every year. So the board has, as part of its board development plan, has a specific action around completion of health and safety training on an annual basis.
I just thought with the publication of the Grenfell report yesterday, it was timely to ask the question. Thank you.
An organisation to do that training with us to make sure that we are then able to discharge our duties from the, I can't remember what the acronym stands for, but the IOSH standard.
I remember that was jolly good training, actually, wasn't it? Very dynamic.
It wasn't just with the board as well. We included our senior leadership colleagues as well. So it wasn't just a board level piece. It was our care group, clinical directors, general managers and heads of nursing. So it was a real wide reaching training programme.
Thank you.
Good question, Adrian. Thank you very much for that. Colleagues were then asked to approve the health and safety general policy as a matter of which, again, is reserved to us as a board. You could indicate, and that will then bring us to Kim. Please, the annual end-of-life care report.
Comprehensively covered in Isabel's quality report, noting that the profile of the service continues to grow. In year, it's grown by 15.6%. It's also important to note that from 2017 and 18 to date, the service referrals have doubled. So that gives you an extent of the growth within that, but also great that we're picking up the 1,000 days of life, that we're able to do the right interventions, but still work to do. Our compliance with our referrals, urgent within 24 hours, we're at 95.3%, non-urgent within 48 hours, 96.8%. But we'd like that to be 100%, but also acknowledging this is one of the services due to the operational demand is under review as regards what that service looks like, and that business case is one of the 5 as well as part of the financial risk. And I'll leave it there.
Thank you very much. I did have one question. It slightly pertains to your last point. I was wondering, with the reported demise of so many charitable end-of-life care projects, hospices, are we seeing an increase in the demand for us, and what might we do about that? Because they're going down very fast at the moment.
It's a topic of conversation Alistair and I have. We have, so I've spoken to Susan Bracefield, who's my opposite in the system. There is now a system end-of-life lead, that there is one within RCHT and one with CFT, but we have to do this as a system to be able to understand how we collegiately work with an ever-decreasing end-of-life services, whether that be hospice or other that's out in the community, considering we make a lot of reasonable adjustments for those who may have wanted to spend their last hours at home, and that has not been possible. So we need to continue that system-wide work, and it is one of our system priorities that we can't lose focus on.
Thank you very much. Isabel and then Alistair.
Yeah, no, I keep commending people, but I would like to just put it on the board's attention, just the passion and energy from our specialist lead for end of life, who came and gave a very comprehensive presentation to us around the end of life service. So we were really grateful for that, and we would have liked to have spent the entire Quality Assurance Committee time with her because she just had so much to say. So that was one thing. And secondly, yes, for those of us listening to Radio 4 driving in this morning, there's a huge amount of pressure now on the finances for hospices, which undoubtedly I think may have impact on us. And we're already facing those workforce challenges that I flagged up in my overview of what's going on with quality and safety. So
thank you for that. Alistair?
Yeah, thank you. I think it's always a good report, and I think the body of the report really well describes what goes on in RCHT. But I think my concerns are around the what we see in the dashboard. So in the dashboard, you can see that over the last 2 years, a number of referrals have gone up consistently. The number of emergency admissions from care homes has gone up. The number of emergency admissions into our emergency department for people with end-of-life care has gone up, and I've seen more recently some population health medicine data which shows that patients in the last year of life are one of the commonest reasons for attending our emergency department. And that's in the context of a team which is struggling with numbers in RCHT, and we've got issues across our system in the provision of out-of-hours pharmacy for end-of-life drugs and those sorts of things. So I wonder whether this is an area of focus that we should be taking to the system improvement and quality group, because I think there's so much aspects of what goes on in things like community pharmacy, primary care, treatment escalation plans, what happens in CFT and what happens in RCHT, which would really deserve that scrutiny, because it is a significant issue for our population, which is ageing faster than the rest of the population.
That's really helpful, Alice. I'm going to bring you in, Isabel, and then I'll come to you in if that's right. So it's on that point.
Just to address Alice's point about the System Service Improvement Committee, which is a relatively new committee, but it's demonstrating a commitment, I think, from all participating partners within that to look beyond the confines of our own organisations. And so diabetes is one area that we have been working on over the last couple of meetings to look at end-to-end care for patients with diabetes, but end of life has already been flagged up as an issue. And I think the task of that committee, the task of the executives, is to go away and to develop a work plan, and I would expect to be seeing end of life as part of that work plan.
Thank you. Thanks very much. Ian? Oh, my mistake. Richard?
Yeah, I'm just reflecting partly the conversation we had in committee about the role of the discharge nurse, because it's such a critical role, I thought, in terms of coordinating discharges, and it was really disappointing that pilot has not been extended. And I wonder if that's Mary's point about funding, and whether that was the issue rather than the effectiveness of that pilot programme. So,
Jim, are you able to respond?
That's right.
Discharge, yeah. It is something that we're just checking with our system partners, because obviously it was commissioned there, and that I do have an appointment with Susan now. She's back from annual leave, and it's on my list because we've had it reported. I'm just trying to understand the backstory, and if there's anything we can do to assist, or whether it's part of a wider programme. And that's why it's really important. We've spoken a lot in both quality assurance committees at RCHT and CFT. It's okay having great or good services in one part, but how do we spread that out so you get an end-to-end service? And we're hoping that the 1,000-day conference that unfortunately had to be cancelled will be rebooked, and we'll be able to all come together to be able to have a look at that.
Thank you, Kim. Does that help, Richard? That okay? Yeah, thank you very much. And I guess that sort of on that last point, Alistair, what you said about the increasing number of end-of-life people coming into ED seems like such an inappropriate place for them. And so I think that's even more impetus, isn't it, to kind of try and get that 1,000 days conference looking at how do we segregate people. And that does involve partners, SWAST and other people, doesn't it? So. Okay, thank you. Thank you for the in-depth discussion. We're asked to receive and note this annual report, and I add to you, Isabel, and add our thanks for the passion with which people who are engaged in this service do so. Thank you. So then we're on to the Controlled Drugs Accountable Officers annual report. That's you, Alistair. I think Jill Derrick is with us.
So just to quickly introduce Jill, who is the Controlled Drugs Accountable Officer, and in that role she's accountable to the board for this. So I'll go to you, Jill.
Yes, thank Thank you, Alistair, and thank you, board, for allowing me to squeeze into your busy September agenda. I know it's been a busy morning. So this is the annual report from the Controlled Drugs Accountable Officer. I've been the Controlled Drugs Accountable Officer since the beginning of 2019. It is a CQC registered appointment, and it is accountable for the legislatory regulation of our use of controlled drugs in terms of storage of it, issue of it, administration to patients, and documentation of its use. So we work with across the Controlled Drugs Local Intelligence Network. I attend those regularly. We have regular communications with the Controlled Drugs Accountable Officer from NHS England South West. And we also have a forum within the Trust called the Controlled Drugs Advisory Group, where we review any issues or concerns and make decisions on next steps as to how to improve our governance processes. I'm ably supported by our Deputy Controlled Drugs Accountable Officer, which is the Chief Pharmacist, and one of our other senior pharmacists. So my gratitude to them for all of the work that they do and all of the work that the whole of the pharmacy team does. As you can see from the report, there is an awful lot of documentation, auditing, investigation of any discrepancies, etc. And they work very, very hard to keep us safe as an organisation and to keep patients and staff safe as well. So we look at a variety of ways of how we can monitor and track the use of drugs, particularly in terms of questions about misappropriation and losses. So we've got 3 ways that we look at that. We basically have, we start off from the ward stocks and the numbers, the amounts of drugs that are issued to the wards. And if there's any sudden increase in orders, then that's investigated. Those are what's called our CD variance reports. And you can see that does flag up some concerns that are investigated regularly over the last year. And then we use our DATEX reports, our incident reports, to look at unaccounted for losses. All of the ward areas do regular daily checks on the amounts and the volumes of controlled drugs that they have in their cupboards. And so any incidents around unaccounted for losses are investigated, and there are various themes that we look at. It's often liquids, and so measuring and tracking volumes of liquids, you always have some losses of that. And there's an analysis of the themes as to why we can get unaccounted for losses, mixing up with certain controlled drugs, so pregabalin and gabapentin, which are one of the lower schedule drugs, but we do treat as a controlled drug, and oromorph and some of the sedatives. And then we look at a wider themes of our incidences, our DATEXs, and that's around inappropriate administration of drugs to, say, opiate naive patients who may be more sensitive to drugs, and wrong administration doses, etc., as well as the unaccounted for losses. I just want to draw your attention to the DATEX trend, the incident reporting trend since August 16. You'll see that there does seem to be quite an alarming rise in the number of incidents reported. Obviously, that could mean more incidents reported, or it could be more incidents. And we've tried to analyse why, what else has happened during that period that might explain some of that rise. So our numbers of patients in medical beds has increased over that time. And obviously our number of the patients that come in are on a higher number of drugs, including controlled drugs. And so that means that they correspondingly that will increase the number of incidents. But obviously, as I say, we do investigate each of those concerns around unaccounted for losses, etc. We work closely with the counter fraud officer for the hospital, and they attend our controlled drugs advisory group. So if there are any concerns about misappropriation or staff health and well-being, then they will be involved with that. And there is some themes of the other DATEXs there. The only other thing to highlight is, as I've already mentioned, the workload from our pharmacy staff to do some of this tracking and monitoring and auditing. And that's one of our recommendations, that we do try and review the resource required and see if there's a way we can make that resource more sustainable, perhaps with some pharmacy technical officers that can help with some of this auditing, or some other way of providing a bit more support for the audits and the reviews that are so essential. In terms of our policies and procedures, they're all up to date. We do meet with our reporting requirements through Medication Practice Committee and Clinical Effectiveness Group, and we do report regularly to the Controlled Drugs Local Intelligence Network too, with any reports that any incidents and concerns required. The other issue I want to highlight is the training, and I think it was highlighted at Quality Assurance Committee, and I took that feedback very seriously. We obviously have a couple of areas that are below 70%, and they are some of the most pressurised areas in the trust, and therefore theoretically some of the areas that we need to be even more stringent around our training requirements. So that will be fed back to those individual areas. And then a brief comment on the Gosport inquiry and our duty to make sure that there are no concerns around unusual prescribing practices or concerns around patient outcomes. And there are no concerns. We do a very comprehensive rolling report every 6 months, and we can check any trends, etc. And we obviously share that information with the CFT wards and the CFT Controlled Drugs Accountable Officer, because pharmacy issues all the drugs to CFT premises as well. So. And the only other thing to say is that there are a lot of personnel changes over the next couple of months. This is my last report as Controlled Drugs Accountable Officer, because I will be leaving at the end of October. The new Deputy Medical Director is starting on the 23rd of September. She will take over that role and undergo her training accordingly and be registered with the CQC. And then our Head of Prescribing Support Unit, who's one of our Deputy CDAs, is retiring but working part-time, so I'm hoping he'll continue to provide that consistency. And Ian Davidson, as our other deputy, will be continuing as chief pharmacist. So there will be some contingency there and consistency there. So the recommendations are, in terms of the only other aspect of the recommendations, apart from the resourcing needs review, is that we have started implementing electronic controlled drug cabinets, which are much easier to audit and track and require digital access, so you can trace individuals accessing the cupboards, etc. So we'd like to develop a rolling plan to replace those across the whole hospital, and you'll see in the report that we've already started with some of the areas where there have been concerns raised about unaccountable losses, etc. So, and I'll take any questions if there are any. Thank you, Chair.
Thank you very much indeed. Another really comprehensive and helpful report. Colleagues, are there questions for Jill that weren't raised at the previous committee? Ian?
Yeah, thank you. Thank you, Jill. And thank you, given it's your last one. I think it's important to thank you for all the work as Controlled Drugs Officer for the Trust over that time you outlined. I wanted to just pick up on page 302 in the pack. You touched on it in terms of the CD checks, the 6 monthly CD checks. So I think the paper sets out the number of areas to be audited had increased, but that was an anomaly in the data. But I noted that only 30 were carried out compared to 53 in the previous years. I just wanted to understand, that felt a concerning dip. That's kind of over 40% reduction compared to what we've done. So understanding we might be struggling to keep up with new demand, it feels like we've dropped back from the level we were able to attain in the previous years. I don't know if there's a bit more detail about what you think's driven that. I know you've touched on the review work in the recommendation.
I think so. There's a comment around the number of theatres and expanding the theatre areas. I think it's probably or realigning those different has added to the number of audits. I think in terms of the workload and the audits that the pharmacy teams have to do, this is probably the sort of lower priority level of audits, which is why unfortunately it has dropped back. at the expense of looking at the unaccountable losses and the CD variances. So I think this is where the review of resources would be required. The other audits that haven't been done are more quality audits rather than sort of quantitative regulatory audits. But again, I think it's been well noted that actually that is somewhere that we need to improve upon.
Thank you. Steve.
Yeah, thank you, Jill. Really helpful report, so very grateful for that. You touched on the one area I was going to ask around, which was the controlled drugs DATEX trend. Noting what the report says and kind of noting what you've updated, it's still, I think, a concern with that trend being so marked. I do note that the data is up until February 2024. So I've got two questions. One, do we have more recent data, and can you share whether, if we do have, has that trend continued? But also, Alistair, given that trend, whether we should ask for a 6-month report to reflect the data from March to August 2024. So not replicating the whole report, but something specific to that, just to give us more assurance that that there isn't an issue for us to consider and act on. So if I could ask the question to Jill about, do we have more recent data, and is that showing us anything? And then ask Alistair about the 6-monthly report.
We certainly will have more recent data, yes. Apologies, I can't tell you off the top of my head what it is. The only other thing to say is that the moving range, which is the range at the bottom, it sort of gives you the difference between each time point. So in actual fact, that's going either side of the line. So that sort of provides a little bit more assurance that there may be other reasons for the rise in terms of increasing reporting, etc. Although I don't understand these charts very clearly. I can certainly take an action and bring that back as part of board actions to for 6 months. I mean, we've probably got most of that data now, so we could bring that back fairly soon for you.
Yeah, so I think that would be really helpful, Jill, because I think if that trend from February was in a completely different direction, then we'd be assured of that. But if it had continued in the same direction, then we want to be really assured that we were doing some sort of deep dive into this going forward. So perhaps and we can bring back an action for next board to clarify what's happened since February. And in the meantime, we can have the conversation.
And perhaps I'll look to Isabel, but perhaps that comes back through QAC.
Through QAC.
Yeah.
Yes.
It's a really good idea, and we could put it on the next agenda for QAC if the data is already available. So.
Thank you. Jill, I don't know whether you're leaving the trust altogether or you're just leaving this role, but either way, can I thank you very much for undertaking what is really a very exacting role, I know, and thank you very much for your report.
That's a pleasure. Thank you very much.
Okay, colleagues, we're asked to note, subject to appropriate capital funding through the medical equipment board, a phased implementation of electronic ward stock cupboards across all patient wards will take place, and note that a review of the resourcing needs, costs and implications of the controlled drug accountable officer oversight, pharmacy controlled drugs and audits, and investigate ongoing concerns across the trust with an aim to resolving any gaps, and then the additional action to bring a report of the last 6 months data back through quality committee to your next quality committee, please. So if colleagues could note this, please. I think we are now behind time. We were doing so well up until 10 minutes ago. Never mind. I think we've got Sarah Coulter with us, our guardian of safe working hours, and you're going to present the Q1 report, please, Sarah. Welcome.
Lovely. Thank you. Mine's probably going to be a quick one this time. It's been the quietest quarter since I've been in post, which is about 2.5 years now. We always encourage exception reporting amongst the junior doctors. We know that it always tails off in the first quarter, April, May, June. We even sent out more emails this time to encourage people to exception report and also to remind them of what they should be exception reporting. I think people forget that it's not just extra time that they're staying late. It's also if they're missing breaks and if they're missing their educational opportunities such as clinics, teaching, etc. for the more senior trainees. So we'll just see what difference that makes, and we reminded them at induction this time as well. It was also quite surprising how many junior doctors don't know what rest breaks they're entitled to as well. So we're just putting together some information to be sent out. I think they were quite surprised when they realised just how much it was. Actually, on the numbers of exception reporting, I wasn't too concerned, apart from endocrine, that flagged big time this time. And I was also approached by one of the trainees in endocrine who was quite worried about things. It was a combination of factors, particularly junior team this time. They had no IMTs, they had no STs. So there was nothing they could do as a short fix. They just had to bring in locums to help support the team. And it also coincided with the medical outlier ward change as well, which also had a negative impact on the endocrine team. So I think that things have been addressed, not wanting to spoil next time, but they've definitely gone down in August for endocrine. So I'm not hugely concerned about that at the moment. On a positive, from the oral and max vax and oncology, with the proactive changes they made, they've significantly improved their exception reporting and the satisfaction of the trainees in those areas as well. So I've also included this time the grade of junior doctor reporting. As we've always known, it was predominantly the F1s and F2s, and it was a single CMT and a single ST4 that exception reported. So all we can do is just encourage them to exception report in the various inductions we do and the meetings that we have. From an accommodation point of view, everyone's reasonably happy with that. I think we would still like something in Trelawney, but I think everyone's very realistic that space is at a premium, but they're pretty satisfied with what we have. And that's probably all I have to say, actually. So I'm happy to take any questions.
Super, thank you very much, Sarah. ST and IMT, could you just translate, please?
So it's the old SHO grade is the IMT and registrar grade is the ST.
Thank you, thanks very much. Alistair, would you like to comment at all on the report?
I think Sarah said most of it. I think the interventions that have been put in oncology and in some of the other services, OMF, have obviously made a significant difference, which is great. I think Sarah's determination to get to the junior doctors to make sure they understand what the exception reporting is about is really important. And we do intermittently get a single person who will put in lots of exception reports. So I think that understanding how many exception reports are coming from one person versus a whole range of people gives you a slightly different feel about what the issues might be. So I think I'm very happy with the report. So thank you, Sarah, for your work.
Thank you, Alistair. Kim?
Yeah, I was just wondering, on page 6 of your report, from the ER, I think it must be Employee Relations Survey, it says there may be negative repercussions, or my supervisor department may not be supportive. If you need any freedom to speak up support from Joe or myself, it just stands out because it's not quite what we say in our freedom to speak up. We're encouraging people to speak out, as opposed to anyone, even if it is one person, if there's anything we can do to support, happy to support Alistair and yourself with that.
Yeah, thank you. We try our best to encourage it. We can say it can all be anonymous. We try to break down the barriers. I think, yeah, it's tricky. Certain specialties are a bit trickier than others, but we're certainly trying. But yeah, thank you for the offer.
Well, thank you. And I'm really glad you raised it, Kim, because it did worry me, because it made me wonder whether we might have a cohort of a type of staff who are not feeling included in the FTSU, or who are not hearing the messages, or, as you've just said, Sarah, it may be that it's specific to some specialisms. And if it is, we need to know that, don't we? Because it stuck out like a sore thumb to me as well, Kim, that we really don't want staff to be feeling like that. And I do think some crossover with FTSU would be a help.
Very defined group, isn't it?
Yes.
Well, and we have had it raised before, Sarah, that sense of collegiacy, isn't it, and confidence. But I think I'm more worried if the supervisors or department weren't going to support, we could do some education there.
That sounds really good. Thank you. Any more for Sarah? Sarah, can we once again thank you so much for the work you do in this capacity. We're going to receive and note the Q1 report from the Guardian of Safe Working Hours, but also note that there will be some support given from our FTSU teams in towards you, Sarah, to see whether we can improve that aspect. So if we could note that, please. Thank you very much. So then that brings us to our journey of improvement, and I hand over to Robin for the integrated performance report, please.
Thank you, Mary. So, noting that we discussed quite a lot of the urgent care metrics in Steve's update, I will just highlight that in the IPR itself, on specific graphs for colleagues to look at, and we did scrutinise both of these graphs in Finance Performance Committee and Quality Assurance Committee, is there is some concerns that we are working through with wait to be seen and the initial assessment in the emergency department. So the standard for initial assessment should be 15 minutes, and at the moment, although improved from previous months, it is still too high at 32 minutes, as you'll see in the report, and wait to be seen, which should be 60 minutes, again improved, but still in transparency, too high at 110 minutes. So that was an area that we scrutinised through those committees. Steve's mentioned all of the work that we're undertaking in terms of our flow actions, length of stay reductions, etc., to assist the crowding in the emergency department. And again, we reference that through to risk 9048 on our risk register, which is the crowding in the emergency department. To bring to the board's attention, our stroke metrics remain a concern for us. So we do note that there is a recovery programme in place, and Bernie George, who leads that programme from Quality Assurance Committee, is going to meet with myself, and we're going to provide Quality Assurance Committee with additional level of detail of how that plan is working and the actions that are being taken to improve that performance. Finance Performance Committee noted that action will be managed through Quality Assurance Committee. We are also undertaking further work led by Alistair's office on our fractured neck of femur, as those indicators are also not where we want them to be. From a planned care perspective, again, Steve's mentioned a number of these in his report, but I'll just bring to the board's attention that we maintained a 104-week breach position. Our 65-week position in July is 290 patients, which is an improvement from 367 in June. We are currently forecasting 56 patients over the 65-week standard at the end of September. We are resolute as an organisation that our annual operating plan was for 0, and we are taking actions with the ambition of achieving that 0. It would be reasonable for me to bring to the board's attention that it's a very challenging target for us. The teams are undertaking an awful lot of additional work to try and bring that home, if you will. They are managing in the realm of 400 patient pathways at the moment to be at that 56 number. So there is an element of risk to that. We keep it under constant review, and I keep executive colleagues briefed on how that position is moving. Our diagnostic performance dropped from 80% to 76%. We've undertaken what we call a deep dive, so getting into a detailed positioning regarding our community diagnostic centres, so known as CDCs. There is an opportunity to use more of that capacity to support our position. We're taking further actions to do that, but also to note for the board and those watching from home, we are making a concerted effort on the time for wait to first outpatient appointment. We call that phase 1 of our elective recovery. That does increase demand for our diagnostic services, so that's what's moving that number about. And we are seeing some really positive improvement. It's not in the IPR, but actually I can tell you that today 40% of patients now coming onto our list are getting their outpatient appointment at the booking window that we would expect to be at if we were delivering an 18-week pathway. So I know 40% is not the 100% we'd want to be at, but in terms of that journey of improvement, that's an important number for people to be cited on. Our cancer standards are delivering to the national standards, but I will highlight to colleagues that the 62-day target reduced for this year, and we are delivering at 80.5%. The previous target was 85%, and we as a board have said that we want to maintain that 85% delivery. So we are undertaking further work through our Cancer Action Delivery Board to recover that back to the 85% target that we are working towards. So that's my operational side of the piece, and I'll go, because she's opposite me, I'll go Kim first.
Thank you, Robin. On page 320, you've already heard me talk about the Euroking non-compliance with the National Patient Safety Alert. The only other one that we have, and it's a national issue, is the notification of bed rails, and that has proved problematic. It is a joint one across RCHT and CFT, and that has taken quite a comprehensive piece of work tracking every bed rail, and I never knew until now how many we use, not just in our services but go out into the community. So we're hoping with the ratification of the new policy that should be completed in September, and the actions within the community which we're supporting on should be completed in October. So we'll monitor that there. The only other thing to raise would be we had a long conversation at Quack about the 5 cases of gram-negative bacteremia, because in particular on Lowen Ward, which is our cancer and oncology unit, hematology and oncology unit, because there seemed to be connected not with any clinical trend, but with concerns around our water system. So there has been an extraordinary meeting held. I have spoken to Brian. The water safety group have met. There's a certain set of actions that are required to be taken, and we'll monitor that through not just estates but through Quack as well, to make sure that they are resolved as quickly as possible. And Robin and I are fully briefed on those. And I'll leave it there.
That's really helpful. Thank you.
Yeah, I think the only thing just to add was around the fractured neck of femur metrics, which you mentioned. So we did have a workshop at the beginning of August, with specifically looking at the one particular metric which has been stubbornly very difficult to resolve, which is the time from admission to surgery at 36 hours. So we had a particular workshop which focused on that. It was well attended by the teams, and an action plan has been drawn up to address that. So we're continuing to take a lot of focus around fractured neck of femur, because it is one of the areas of our time pathway where we know the quicker we get to surgery, the better the outcomes are going to be. Thank you.
Robin, I just had a question on that. So Alistair, thank you for touching on those things. I just had a question on the fractured neck of femur, and clearly really appreciate what you've said. How well do we do with pain control in fractured neck of femur that's not being able to be processed? And the reason I'm asking is because I think a lot of these people are likely to be frailer, older people. And I think some of the research shows that, a bit like young children, we're not as alert to pain in these groups. How do we fare on that?
And actually, I've seen some data recently, and I'm struggling to work to remember the exact figures, but there's been a significant improvement in our pain relief. And we were already benchmarking well in terms of pain relief in fractured neck of femur. It's still not as quickly given as I think it should be, but there has been a big push in our particular pathway to get the regional block, the regional anaesthetic block, done in ED when they first arrive, and that's a real positive movement in the right direction. But actually, the things that make a difference in terms of outcome is getting to the right ward and getting to surgery within 36 hours.
Thank you. I think it'd be really useful to monitor that, because it's a bit, as Megan was saying to us earlier, you know, a lot of much older people just say, it's all right, dear, I'm all right, because they've accepted a level of pain which is unacceptable. So I think to kind of hear back, perhaps again through quality, would be really useful. Thank you.
Just going to then shoot across to Alison, unless you're coming in, Kim.
Sorry, Maury, we'll pick up with, so there's been a concerted effort with our trauma coordinators. So the pathway from ED to the ward, then from ward to theatre, then the post-op analgesia between theatre and back into the unit. I think we've seen that improvement as well because of the splitting out of the 2 wards and it being a concerted effort. It has been a national problem over many years. I won't tell you when I did my thesis as an orthopaedic nurse, but that was one of the issues. And it's that perception that, you know, people will often say, I'm not in pain, but you're about to be mobilised. So you are going to, so we will pick that up through both our programme of work as well as reporting back through Quality Assurance Committee.
Thank you very much.
Now across to Alison, if there's any elements of organisational development.
Thank you, Robin. So I would just like to point out regarding our sickness absence levels, although there is an increase in July, that was predominantly down to respiratory, cold, gastro and flu type symptoms. Actually, within that increase, there is a bit of a good news story, which this masks, that actually our stress has now dropped to being 7th in terms of the reasons why staff are off sick. But as I say, we did see a lot of respiratory issues in July. Turnover is static, vacancies are fairly static. Appraisals have also hit a bit of a static position as well, only slightly increasing this month to 74.3%. It's now very clear through our corporate performance reviews. We've got some care groups that are doing really, really well, and we're now trying to work with areas that are dragging the overall trust percentage down on appraisals. Statin Man, we continue to participate in the national project, which is reviewing all statutory, mandatory, essential training. That has resulted in some changes happening within the amount of training that people have to take within the trust, and I expect to see that continuing to change over the next 6 months as well. But I do need all staff to continue to commit to completing their essential training. Thank you.
Thank you, Mary.
Thanks very much, Rob. I think Uzma had a question in the chat. If you could repeat it, Uzma, because the public can't see the chat.
Alison, it was just a question on the reduction in stress-related absence and whether we have any indication of measures that may have contributed to that reduction, and if so, can we keep those up as we enter the busier winter periods? Thank you.
So we'll continue to use all our existing resources that we have available, which includes our EAP system, our occupational health team, although that is also a fragile service. We might have to review our counselling due to funding, but as I say, there's a lot of support that is given across the trust, across many teams. We've talked a lot today about freedom to speak up with chaplaincy, the HR teams themselves, as well as other support from senior management. So all those normal processes will continue through winter.
You, Ella?
Thanks. Yeah, I just wanted to, you'll notice there's a little purple box saying year 2 priority against some of the metrics within the IPR, and they're the metrics that we use to measure our absolute kind of strategic priorities each year. There's one, Alison, the Staff, Friends and Family Survey recommended the trust as a place to work, which, whilst it's not flagging yet as a statistical kind of outlier, I think the deterioration there does warrant a bit of a deeper look, and perhaps given the very positive work last year and the improvements made, we may just want to give a bit more focus onto that one.
Yeah, thank you, Ella. Other questions, comments? No, in which case, thank you. We are asked to discuss for assurance. Oh, sorry. Sorry, I didn't see you.
Yeah, I put my hand up after you said no more. I'm so sorry about that. Just an observation question on the graphs themselves on 2 particular pages, the finance graphs. So page 350 357 and 358. I'm not sure we're consistent with what's being reported in the graphs with what's very clearly outlaid in a later document, the Q4 revenue position. So just to flag 3 areas, which I think I flagged at Finance and Performance Committee as well. On page 357, the bottom right graph, variable income, I think we're doing better on variable income than plan, and that's very clearly outlined in report 12.1, and that's not coming across in that graph, which is showing that we're perfectly on plan. On page 358, the top left graph, agency spend against plan, I think we've been above plan for spend in the first 3 months, but we're getting closer to plan now. So there's a positive there in terms of addressing our actions, but that's not coming across in that graph. I think there's actually an error in the bottom right graph on page 358. Forecast from current SIP from memory, our target is 60% recurrent SIP, not 40%. So we are performing even more badly than that graph is showing, which is very clearly outlined in the report 12.1, which Ian will talk to later. So just flagging some inconsistencies in the data.
That's really, really helpful, Adam. Thank you. Glad you got in. Ian, do you want to comment at all, or could we just make those corrections?
Yeah, happy to take that as an action, make those corrections. I think on some of them, like the agency spend against plan, because they're cumulative graphs, it doesn't quite, with the scaling of it, doesn't quite help pull out. So we'll check them for 2 things, for data accuracy and for informativeness for the board when looking at them through a graphical format. But thank you for raising
And
them.
if they do need correction, we better notify it through the minutes if we could. That'd be really good. Okay, thanks, Adam, for catching me. Okay, we've discussed for assurance the month for performance under the domains of safe, high quality, supported and valued people and journey for improvement. And there's one action which Lindsay will note. So that then would bring us, please, to Richard, your assurance report from the Finance Performance Committee, please.
Thank you, Chair, and again, take the report as read. It's a long report, so I won't go into great detail on everything. Just to remind people in the public gallery that this covers July and August, so it is covering 2 months. As always, I think I'd ask the board to particularly note the decisions that have been taken by Finance and Performance Committee on behalf of the board under its delegated authority. And also note those items that are referred to the board and recommended on for decision. For example, the cardiac relocation project, which we considered last month, and the premises assurance model, which is on the agenda today. You'll see in the report there was one item being escalated to the board. That came from the July meeting, and it was the need for greater consideration around the financial and operational position of the trust. And as Steve laid out in his report earlier, that's within the national context of pressurised services. That was discussed in August at the board, and that went on also to be discussed in a development session of the board. And Steve laid out again in his report, in the verbal additions to the report earlier, some of the additional measures that have been taken as a consequence of that consideration. And I think it's worth just pausing very briefly to reflect that the nature of the way we operate as a board, that we've tracked through month 1, month 2 at Finance and Performance Committee, where we haven't been able to secure those assurances around the risk against performance on the financial operational plan. We've then taken the role to escalate to the board. The board has had that greater and wider consideration, and that's led to the further action. So it's just the way in which our governance works. It's helpful to remind people, I think. The board will also note in this report the number of items that carry partial assurance. By and large, they refer to the items on the agenda that we've considered that are around the operational financial performance. There are some exceptions to that, but largely it's working under that pressurised environment where we're getting the partial assurance around our performance metrics and the financial operational against plan. I think the only other thing I'd raise is where we Find partial assurance, again, just around our governance processes. All of those within Finance and Performance Committee are then referred into our discussion around the board assurance framework and our assurance around risk. And again, later on the agenda today, we have that discussion around the board assurance framework, which will reflect those discussions that occurred at Finance and Performance Committee based on those elements of partial assurance. Happy to leave it there and take questions.
That's really helpful, really comprehensive and really good report. Thank you, Richard. Are there questions specifically for Richard? Steve?
Yeah, not a question, just to add some context to Richard's summary and just to refer back to Adam's challenging comment about recurrent levels of CIP. We would anticipate, Richard, that the month 5 financial position would be reporting a recurrent CIP level of closer to 40%, following a set of actions taken in response to the escalations and the actions that were required in the Finance and Performance Committee, and were also considered and required when we met as a board as well. That is a significant step forward, although clearly not yet at the 60% level that we're looking for. But I think we should be able to be very clear on the impact of the actions that were taken following those escalations.
Thank you, and we look forward to that feeding itself through Finance Performance Committee. It might be also worth just noting that yesterday we had a discussion, members of Finance, all the chairs of the committees, because cost improvement programme cuts across. There's one which is financial, operational, but obviously there's a quality and safety issue to the way in which we make the savings, and there's people, workforce implications of that, and audit and risk implications. And so we collectively put our heads together with the lead executives to think about, perhaps, is there a better way of reporting that? We've yet to determine that, but hopefully we can find a different way of reporting SIP, which will help us, cost improvement programmes, which will help us.
Great, that sounds really positive. Thank you. Thank you all for that. So, okay, let's then note that report from the July and August Finance Performance Committee and move on, please, if we may, Ian, to the month 4 Revenue Finance report.
Thank you, Chair. So I'll take them.
Oh gosh, sorry. Adam, I'm so sorry.
Yeah, it was so.
I put your mic on, I think. No.
Okay. I'm not sure that's me.
Is your laptop microphone on?
It hasn't been, so I haven't done anything different. Okay. All right, thank you. Sorry about that. So I'm sure this will happen at Finance Performance Committee. It's really good to hear about the significant improvement in the recurrent SIPs. That's fantastic. But I think we need to make sure that Finance Performance Committee gets the information about how we've managed to achieve that significant improvement. And that's, I'm sure it is, but that we can see that robustness behind that significant improvement. I'm sure that goes without saying, but I just wanted to say it. Thank you.
Well, I'm glad you said it, Adam, because one of my thoughts, which I chose not to say, was, so we really need to learn from what's enabled us to do that, so we can apply it to the next 50% of the 60 that we need. So, yeah, great, thank you. Ian.
Thank you, Chair. Yeah, and absolutely, Adam, we will make sure we do that as part of the update. So I'll take the report as read. I'm probably going to spend more time of the allotted time on this report than the capital report, just to give board members that heads up. For reasons that become obvious as I go through some of this. So this is the report to the end of month 4, and we are currently 3.5 million adverse, so off our plan that we submitted. Within that, we do have the cost of the industrial action that happened earlier in the year of around £1 million, so excluding that is a £2.5 million variance to plan. That's increased from 2 million at the end of quarter 1, so at the end of month 3. So we continue to have an in-month deficit month on month. We must deliver our agreed financial plan of break even. That messaging, I think my reflection to board and to members of the public, that is very consistent. It's coming from the very highest levels of government in terms of the need for systems and organisations to deliver the plan that was submitted, noting the risks around that and the balancing of priorities, which we recognise are competing priorities with some of the operational aspects. On the industrial action element, an update that's not in the paper is that we've now had confirmation that that will be funded in line with previous years. We don't yet have the value confirmed, so there is still a small element of risk that the value we get funded might be different from the value that we incurred as part of the cost of covering that. And obviously with the pay award settlement, that risk is hopefully a reducing one going forward. Following the reporting of the month 3 positions, a conscious public board has only seen this previously, hasn't seen the month 3. We did, in private board, as colleagues around the table will know, undertake a detailed discussion on financial recovery and the actions that we need to take to deliver that requirement on us. And that continues through our weekly executive reporting using the NHS England template for those systems in intervention, which we're not in, but we're using that as a way of ensuring that we maintain the progress we need to. Steve's touched on the board-to-board meetings. I won't go into any more detail on that, but that again is part of that oversight and assurance role that our ICB colleagues rightly have of us as a provider and their responsibility for our system. In July itself, we had an adverse variance to plan of 650,000, which, when you exclude industrial action, would have been about 260,000. That sounds promising, but it's worth noting that that was achieved by earlier release of some of our planned mitigations this year. So some of our release of accruals relating to annual leave that's held at the end of the year, we've brought forward. We've done that very overtly. We've done that in conjunction with myself and the Chief Finance Officer at the ICB and with regional team awareness. The rationale for doing that is to demonstrate our ambition to try and keep on track, recognising that some of the actions we've taken will have a lead in time to deliver. And so essentially what that does is it provides us some limited time to enable those financial recovery actions to take greater effect. And we would expect to see some of that in month 5, but more again in month 6. And I think, as you would expect, we'll continue to closely monitor this every month. We are assessed by NHS England for our level of risk in terms of delivery of the financial plan in particular. We were previously at level 2. Based on our month 4 reported position, we moved to level 2+. So that's an indication that we're moving to more concern. So level 4 is the highest level of concern where intervention would be required. So that, I think, reflects one of the aspects that is based on is our level of recurrent SIP, hence the actions that Steve's just alluded to, but also how confident they are in our plan to recover. So it's worth members of the board probably are aware, but also members of the public being aware that our system has now got a recently started system recovery director, and I'm working very closely with them, as the whole exec team are, in terms of how we get those plans as robust as they can be. And that will provide that assurance both to our ICB colleagues through the board-to-board mechanism and to our regional team in terms of the work we're doing on that. We continue to have good performance on our elective activity, as is referenced in the IPR. That has a financial benefit, and that's really important that we continue with that. There is some risk with that in that we haven't yet seen national publicised data on that since month 11. So our regional team now have the month 12 and the April and May view of that, but that hasn't yet been released to systems. So I'd hope to be able to, at the next board, provide a further update on that and whether that's a positive or a negative impact on our overall position. Agency spending month, so a positive movement down from 1.6 to 1.2. So board colleagues will remember that July was our step change month, where our plan was to deliver £1 million agency spend, and we were previously running at around 1.6 million. So that reduction has been good. My initial view of month 5 is that's crept back up slightly to 1.4. So I don't think we've got yet a sustained position on that. And that's predominantly one of our main areas of that still is medical agency. But obviously we do get some fluctuations in nursing agency. But we continue to make good strides in terms of our healthcare assistant. We don't have any agency usage in that area. And so there are some positive signs in that. clearly without action, we risk a deficit. The plan talks about the forecast range. We've met with every care group as part of their month 4 forecasts. Most care groups' forecast positions improved in month 4 compared to month 3. So the top end of our range of potential forecasts has come down slightly from being around 20 million to probably being more in the region of 18 million at this stage. But that still is a significant distance away from a break-even plan. So there is continued work with care groups and a very clear ask to care groups and corporate teams to make sure they are living within their own means as per the budget and the plan that was set at the start of the year. I think one of the biggest things I'd want to touch on is the process we've kicked off over the last month or so, and for our members of the public watching and staff in particular to be aware of, is our review, improve and benefit approach to communicating our financial position, but also the opportunities that exist in our organisation. And so we've shared widely with all budget holders a pack that hopefully, and feedback so far is positive, helpfully explains the challenge we have and the competing priorities, and particularly the fact that we were £2 million off plan at the end of the first quarter. We've run a number of Let's Talk sessions, and I'm really pleased I've been completely supported by all of my exec colleagues in facilitating those sessions. We've had good engagement and good, honest discussion, difficult discussion, but good discussion with members of staff in those meetings. And I think what's been really promising is some of the insight we've gained from that. So colleagues being able to identify in their areas where there is that opportunity. So I don't think any of us sat around this table think we have all the answers to where the opportunity rests. The best place for that to come from is from our teams and our people that are closest to our services. So the purpose of that is to really kind of make sure that messaging is clear. And I think that's an area that when we reflected as a board previously, that communication piece was something we wanted to do much more on. So happy to take any kind of questions specifically about that if there are any. I think other than that, we've touched on the recurrent SIP elements. I'll just finish then on our cash position. So you'll note in the report our cash position looks much healthier at 20 million, just over 20 million pounds. That's in significant part due to support we've had from our integrated care board partners in terms of managing the cash position at a system level. So there are some elements of cash flow, for example, the payment of elective activity over performance runs with a lag effect, and our ICB have been helpful in terms of managing our cash position on that. So I wouldn't want our board colleagues to take false assurance from the fact that that number looks better and is above plan, because that's a timing element. We will continue to follow that through, and we've previously approved at board in private the application for our cash support that was outlined in our original plan later in the year, and I'll keep board updated in future meetings around that. So I'll probably pause there and take any questions either on any of those bits I've added or the report itself, Chair.
Ian, thank you very much. Really comprehensive report and very excellent exposition of it. I've got one hand up at the moment, so Adrian, you go first.
Yeah, just you mentioned the just over £1 million cost of the industrial action, the last industrial action being met centrally, but not sure if we would get the full. Did we get the full what we were expecting on previous the industrial action?
Yeah, so the answer to that is no, we didn't. We had a shortfall. So I think in the most, from memory, in the most recent one in last financial year, it was around about £500,000 shortfall. That was a combined. So I think that was for over 2 strike periods, and that was consultant and junior doctor action. Whereas this one in June and July was junior doctor action only. Informally, the regional team have calculated a number which is in line with what we would be expecting, but it's a national calculation and it's done based on the number of junior doctors you have. It's not the normal allocation of funding mechanism. So we will wait to see, but I don't think the risk is as material as £500,000, but there could be a smaller level of risk in that.
Thank you, Ian and Adrian. Robin.
You're right, Ian. Everybody is finding this to be it's a really challenging piece, but I think people are trying to tackle it head on. We had a really constructive session in our operational leadership group yesterday, supported by members of Ian's team and Ella's team, and that's with our clinical directors, our heads of nursing and our general managers. We'll open forum, no daft questions type environment where people are trying to work through this, and also encouragingly wanting to talk in that space about what can they do in their care groups, and then what can we facilitate helicoptering up a bit and doing in the cross care group space. I'm not saying that we came out of that with all the answers, but I think that's reassuring that that's happening. And knowing that colleagues also watch this board, it's worth reminding colleagues that do please come forward with your ideas. We really, really want to hear what you know on the ground and what you're seeing. And there are a few trickle into my inbox. I know we've got the Q Ideas route in, got the QI ambassadors that Ella has worked so hard to create across the whole trust. You use them and use your care group management teams as well, because they will be very grateful if you've got ideas that you can share with them. So just wanted to put a plug out there for all those routes that colleagues who are watching could also utilise.
Yeah, really, really helpful. Thank you. And I guess my question kind of is on the back of your Let's Talk sessions. Sounds really good that you're having those sessions. I suppose my concern is how deep the understanding of the clear financial messages really is. So it's great to hear what you're saying, but I just wonder how we're getting it even deeper through the organisation. And barring my suggestion, we had T-shirts with that written on them. Because I think it matters, because it speaks to your point about ideas coming through, Rob, but it's also to people perhaps being mindful of not doing things. And I think the bit on the agency medical spend does continue to concern us. And I take what you've said, Alistair, but I suppose my question is, and it's to everybody really, how if I went out and spoke to somebody out there now and said, what do you think about money around here? Would they know?
I think that's a really good challenge. So the way we've been running those Let's Talk sessions is that it's a cascade communication. So that's been very deliberate, and Laura and Carolyn in our comms team have been fantastic support to me and Ella and others in that. We're encouraging people to take that pack, and it's a pack designed to be able to enable them to have that conversation, not to require myself or an accountant to be able to do that. I think that's a good challenge though. So the question I challenge myself with, how will I know if it's having an effect? I think some of that will be the ideas that we see come forward through it. And we've seen a lot linked to sustainability already in terms of switching off lights, having timer things, not having paper towels and hand dryers, some really obvious stuff, but all of those little elements add up to make a big difference. I think it's probably something that as a board we should take into our kind of list of things in our head when we're on walkarounds and when we have opportunities, so that we test that. And do staff out there really kind of feel that message is getting through to all levels, because that's the objective that we need to achieve.
Great. Make sure we ask the questions. Isabel?
Yeah, I think also it might be worth slightly reframing it in terms of looking through the quality lens as well. And I'm sure others, quality ambassadors are doing this, but we know that if we can improve the quality, we can drive out costs at the same time. Rather than the sort of let's all switch the lights off, which we need to do, but also what could we be doing to improve the quality of our services, which in turn could therefore result in efficiencies around cost.
Yeah, absolutely. And that, along with Kelvin sat to my side with digital and how we use our digital tools that we've got available to teams to maximum effect. So that's the whole purpose of the review Improve Benefit, is to review all aspects of how we deliver services and care, how can we improve them, and what benefit that gives in its broadest sense, because often the financial improvement falls out of doing things the right way at the right time in the first place.
Thank you for that. Steve and then Alison.
Two points. First one's on the how do we know the level of understanding. I think that's a really important challenge. In addition to all of the mechanisms that Ian outlined, we've also done trust-wide communications, and that has certainly generated some feedback from colleagues within the organisation, identifying opportunities for change and identifying risks, issues and challenges. So we, I think, should keep testing how we embed that throughout the organisation. Then the second one, just Isabel's comment made me reflect. I think you're absolutely right that if we enable improved quality in almost all instances, that will enable a more financially viable position. If we think about the frailty same-day emergency care as an example, if we can harness the potential that's there, that can provide a better place for care to be received and could be instrumental in helping us to reduce some escalation costs. And that just made me reflect as to whether it would be helpful in each of our committees then going forward to have a real focus on this for the rest of this financial operational year. Clearly, finance and performance is steeped in that. But for the financial recovery plan, perhaps to also have that same level of focus at People and Culture, at our Quality Assurance Committee, not to duplicate work, but to give that opportunity to test, is that plan delivering our quality and workforce ambitions, and are our workforce and quality plans delivering the financial contributions that we have? And I know we do some of that, but that might help increase the opportunity to identify further steps and actions. It might also support our ICB board colleagues' request for oversight through not just their board, but through their equivalent committees as well. So we could perhaps give that some further consideration as to what format that could look like. And I know Alison's put a comment in the chat that members of the public won't necessarily be able to see about a set of actions to help address, for example, medical high-cost locum spend. That could form a really useful part of scrutiny and challenge in our People and Culture Committee, as well as through the board.
Really helpful. Thank you, Steve. Alison?
Yeah, I was just going to comment on the pack that Ian and colleagues put together in terms of my own experience within my own team, that actually the senior leaders have run with that pack, and it did result in a conversation that was from a quality perspective and a very wide-ranging conversation. So you had people in the OD team thinking around drugs, the cost of drugs. So, you know, it was a conversation from a quality perspective, and it absolutely went down to all of the team. So I just wanted to give that assurance from my own perspective. Thank you.
Really good to hear, Alison. Thank you very much. Ella, you had your hand up and put it down. Is that sort of...
Well, I was agreeing with Steve, really, because I think after the meeting that Richard alluded to, mentioned that we'd had with each of the committee chairs, taking their feedback, we'd landed in a very similar position to what Steve has suggested, that we'll have a financial recovery report that goes to each of the committees. It'll be the same report, but it will pull out for each report, like our quarterly strategic review does, but this will be a monthly report, the pertinent issues for each of the committees to consider, and we were going to trial that in September. Was the
Great. That's sounds really good. Thank you for that positive action. So on the item 12.1, we're asked to note the July month 4 financial position, which is adverse to plan, driven by pay overspends, and to note the recovery actions outlined to address this. Also to note the key issues, as well as the risks and mitigations that are set out in the report, and then to note the future action of a report coming to all the committees, as Ella has just described. So thank you for that. Ian, you're going to go on to the month 4 capital report, please.
Yeah, thank you. So I will keep this briefer. So taking the paper as read, you'll see that overall expenditure of just under £9 million year to date is just under £2.5 million. Behind plan, single most contributing factor to that is the e-health programme boards, where e-care is 1.7 million behind the plan that we expected. That's to do with the timing of that programme and where we're at from a contractual perspective. But we expect that to be fully caught up and spent by the end of the year. So at this stage, not particularly raising any kind of formal concerns to board regarding that. Our forecast continues to be that we'll spend our allocation in 24-25 from a capital perspective. There are emerging risks on that, and we'll be considering at what point a reprioritisation might be required in terms of slippage against current schemes and in-year requirements that are necessary. The process, as normal, around this time of year has started in terms of capital prioritisation for next year. There's details in the report in terms of capital planning for 25-26. It won't be any easier, let me be clear. We will continue to have an oversubscribed capital. We don't yet have a capital allocation beyond this financial year. So that's something we need to continue to be mindful of. And then the only other point I wanted to pick out was in section 8 on page 408, it talks about the risk in regards to Women and Children's Hospital project fee funding. That remains outstanding. So it is said in the report we'd hope to know by the end of August. We're still awaiting a further update on that. So I'll be picking that up with Brian because mine and his leave haven't, they've overlapped. So when he's back next week, we'll be picking that up in terms of next steps on that. So we're board asked just to note that at this point, but happy to take any questions, Chair.
Thank you. Thank you. We hear your assurance about the spend. Colleagues, are there questions? I suppose mine is just the one on the Women's and Children's Hospital fees. I think it's a tactical thing, but we haven't heard back. Does it make it worse if we pursue it, or does it make it better if we pursue it? And it's difficult to know, isn't it? Are there reasons why we haven't heard back?
Not that I'm aware of, but I've returned this week from a couple of weeks leave, so I'm slightly out of the loop on that. But I'll be picking up, as I say, with Brian. I don't know if Steve or any other colleagues have got a more up-to-date position on that.
That's to update on it at this point.
Okay, that's great. So no further questions, thank you. Could we note the financial position for the capital programme for the period to the 31st of July 24, and that we expect to operate within the capital departmental expenditure limit budget this year, and note the point we just made, we've not yet received the Women's and Children's Hospital project fees. So if we could note those, please, and see if Phil...
Right, before we move on, apologies, I wouldn't normally bring us back on an agenda item, but just reflecting on the month 4 report,
yep.
It's implicit in our discussions that there's a requirement for us to return to a break-even position. And it's more than implicit. I think there's a set of actions that Ian has outlined really well, but whether we need to kind of more directly note an action from the board for myself and our executive colleagues to conclude that financial recovery plan to get us back to a break-even position. That runs throughout the report and the update that Ian's just given, and it's probably just stating what is already the case, but whether it would be helpful. I know that's been the determination from our Finance and Performance Committee colleagues. So I think Richard wanted to comment.
Richard?
I think Finance Performance Committee would welcome that, because it gives us, again, more authority and delegated authority to really pursue that assurance. It's as is more than alluded to, this is about slowing the ongoing rate of spend, and it's also finding some of the recovery of the spend that has been overspent to date. So the more authority the board wishes to give to FPC, Finance Performance Committee, to act on its behalf to pursue that, it would be really helpful. Thank you.
Yeah, so thank you, Steve, for raising it. I think it's probably worth being explicit about it. So that is the direction of travel. Obviously, following our board-to-board meeting, I talked about the system recovery director, and I met with her yesterday exactly on that point about how we get that collective assurance, because we are doing this as a system. And not only do we as a board need to be assured that the steps and actions we're taking can deliver us to a break-even position by year end, but we also need our ICB colleagues and our NHS England colleagues to have confidence in that. So I think it all plays to that same point, but it's really worth pulling it out explicitly. So that will feature as part of the month 5 report and updates to board.
And go through finance performance and then report back to board.
Yes, absolutely.
Yeah, that's really helpful. Thank you. Richard?
I suppose the PS to that point is, as well as the financial recovery plan for this year, is to ensure the sustainability of those plans and thinking now for 25-26 as well. And again, routed through the committee.
Absolutely right point. Thank you. Okay, I think that's enough on that one. So if we could invite Phil, are you with us? Phil Bond, because I understand Brian's away. Yep, Phil, you're there. So that brings us to our premises assurance model, please. And I think you're going to present it for us as succinctly as you are able. Welcome to the meeting.
Thank you. So taking the report as read, the premise assurance model is a nationally mandated annual return requiring trusts to provide assessment against 6 key compliance areas for estates and facilities. Self-assessment is undertaken by our subject matter lead and support from the estates and facilities governance team. We're expected to report on the 13th of September, so we're just about there. Since the return in 2023, we've seen some more of our self-assessment questions move to requires moderate improvement. However, 108 are rated as good and 6 have been rated as outstanding. Some of the areas rated outstanding include roles and responsibilities around our fire safety team and also the review process, our review process in decontamination, and risk assessment for our helipads done really well. We have some areas that have been rated as inadequate and requiring improvement. These include costed actions for security and requirement for a new food and drink strategy, that's being taken through the nutrition steering group. Where areas have been rated as required moderate improvement, we're out or lower, we're looking at costed action plans for those to be completed and updates within the next 12 months. So we're anticipating seeing some improvements to that in next year. Finally, we also undertook a peer review with our South West Trust colleagues and also NHS England, which we found really helpful, gave them some feedback on how the premise assurance model works, and it was a really useful process as there's not a benchmarking undertaken elsewhere. Thank you.
Wow, wonderfully succinct. Thank you very much, Philip, and thank you for the report. It was interesting to note the variance in some of the outcomes, wasn't it? So, colleagues, are there questions for Phil? Isabel.
Yeah, it was just a question really, and I know we have discussed this before, but I just wanted an update around the area of security management, because we're aware of the need for additional resource going into security, and we're also very aware of our financial situation. But I just wondered whether there is any progress in terms of actions around improving our security management.
Because we were employing a lot of people who were effectively agency or whatever the equivalent. Yeah, Phil, are you able to respond to that?
It's not something I'm able to answer. That's something Brian would need to pick up, I'm afraid.
Could we possibly ask Brian to provide a further update to us?
Rob might be able to help us.
Brian is currently undertaking a full review of our security provision. In light of the challenge we rightly put back to ask on the previous submission to the business case group, is there a more economical way of delivering the right level of security? But he's also incorporating what should be the standards that we deliver from a security perspective, again, in that roles and responsibilities space as well. So I think it's reasonable for someone to come back. We'll agree which committee it needs to come.
I'm just trying to think which committee it would be. Yeah.
Talk in the lunch break about which committee would make sense.
Audit.
It should be audit.
Yeah, audit and risk assurance committee, assurance around security. Obviously, the business case, any business case will need to go through any business case approval routes, which could include finance and performance committee. But we have a NED lead for security management.
Yeah. Thank you. Thanks for responding to that, Rob. Adam, managed not to miss you this time.
I'm sorry, I think possibly Lindsay said most of it. That's from memory, and Ian or Richard might correct me if I'm wrong. I think the plan for the business case for any required investment in security was coming to Finance and Performance Committee in September. I'm very conscious that was before the latest situation in terms of the financial challenges, but that was the plan a few weeks ago. I don't know if Ian has any update on that.
I don't know. Right. I know that Brian's been working on it for some time in terms of the challenge, exactly as Robin alluded to. So we can double check that as part of the agenda setting for September to see if it's still on track for that.
Well, then, were you indicating?
I was going to ask the new helipad domain. It says that we've moved to outstanding for risk assessments and mitigations, but also obviously identifies that there's a requirement to improve our dam wash capabilities. So I'm just wrestling a little bit with how those two can both be correct. So maybe that needs to check.
Did you hear that, Phil?
Yes, I did. Yes, the difference between the downwash wall and the mitigations around that. So the risk assessment has been completed. However, there are some mitigations in place. We have a new downwash wall that was completed, and there is further work. I think they're doing on that.
Thank you. Rob and then Steve, I think.
Just on that, so we have a helicopter landing site user working group, which I chair, and it includes the stakeholders, so the air operators as well, and that is undertaking risk assessments. It is just finalising it's finalising the specification for our main helipad, and then we plan to be making bids to pots of money that sit nationally that are designed to support all hospitals with bringing their helipads up to the newer standards. So that work that's being led by me will then feed into that helicopter element that's in this report.
Thank you very much. Steve?
I was just going to make a really brief comment about business cases. Of course, we still can consider business cases for approval, but the reality from a funding perspective is the only variable source of revenue we effectively have is activity, additional activity funding. For anything else that we consider to be a key strategic safety priority to invest in, we can make those decisions. We would have to identify a funding stream for them, and in most instances, any business case would actually require a triple lock approval mechanism if it's outside of the activity-related recovery fund mechanisms. So business cases, including security business cases, can be considered, but there are some significant governance considerations to enable them to progress.
And really important point to make as well. So thank you for that. Lindsay?
Thank you. I was just wondering if I could just conclude around the seeking assurance around the security case anyway, and note that obviously we can take an update through, ask for an update through our executive leadership team, through Audit and Risk Assurance Committee, and obviously in the absence of any formal assurance being provided today, we will seek that from our Director of Estates and Facilities, and we can update the board outside of the meeting through any internal communication.
That's really helpful, Lindsay. Thank you very much. Ella?
Thanks. In section 10, it notes that peer review has been agreed, and that was going to take place on 31st of July 2024. I just wondered, Phil, if we know when and how that will be fed back and up through the organisation so that we can get a view on what the peer review and benchmarking is telling us.
We haven't agreed a route for that yet, but it's something I can take away and arrange. So thank you.
Thank you.
Okay, are there any other comments for Phil or questions? No, thank you. Then we're invited to note the report and endorse the premises assurance model, agreeing to the self-assessment question ratings to be recorded on the national reporting system through NHS Digital, noting the premises assurance model is dynamic and is likely to attract further change as referenced in paragraph 1.7 prior to the final submission, and also to note the governance structure for providing assurance. Thank you. And then to note the point of the matter around security coming back through audit committee. So thank you, board, for that. Unbelievably, we're a little few minutes ahead of ourselves. So reward for good behaviour. We will come back, please, at 12:30, not at 25 to 1. How about that? So you get an extra 4 minutes for lunch. So well done. Just think if we keep this up all day, we might be able to go home at 4. So back here for 12:30, please. And thank you for all the work so far. We'll see you later. In the room, please. Thank you all very much for coming back in such a timely manner, and hope everyone has had the chance to have a short break from what does feel like a long morning going into a day. So we are now coming into our valued and supported people section of our report, and as we've done throughout the morning, Adam, if you would be good enough to give us your committee chair assurance report, and then we'll work through the other sections as we have been doing. I have already received a note, thank you, Alison, from you, saying you might be able to take 2 or 3 together. So if that seems to be the right thing to you, then we will look forward to that. So over to you, Adam. Thank you.
Thank you, Mary. So the People and Culture Committee Assurance Report starts on page 424 in our pack. And to briefly summarise that, assuming colleagues have read the full document, the following 4 items on our agenda have all been through the People and Culture Committee, either the May meeting or the July meeting, covering either annual reports or annual reports and action plans, or action plans for 24-25. And as Mary just said, Alison, I'm sure, can talk us through those if we need to. 2 items we flagged from the July meeting for the particular attention of board, and I guess probably both of them we've discussed to varying degrees in this meeting already. The first was around recognising the challenging workforce efficiency programme we've set ourselves as part of our financial challenge, and making sure that we wanted the board to be very cognizant, which I know we are, of the challenge of that, and the challenge around making sure that we properly consider the safety, the quality, and the financial implications, as well as the workforce implications of that programme. And we've kind of discussed that a lot in this meeting. And I think Richard started the conversation around, we've had a really good discussion about how we can better triangulate between the different committees and improve the robustness of that. So I feel like we've discussed that already in this meeting. And the other area to flag, which we flagged before, again, it's a work in progress, I guess, is the need for a wider system workforce strategy. In particular, I would emphasise the need for a medium-term system-wide workforce strategy. And I think this, Richard, on my right, flagged the point around the financial perspective that we need to be considering not just 24-25, but 25-26. And that equally applies to our workforce. And I take it further in both in terms of finance and workforce, that we need to be considering 26, 27, 27, 28. What do we need the workforce to look like? What's our financial constraints? What are our quality implications? How do we triangulate all that better? And we need to do that with our system colleagues, is what we're talking about. So those were the 2 issues for escalation to board. And then probably the only other thing I would flag, I think again in a similar way to Richard, Chair of Finance and Performance Committee, is there are a number of items where we only felt able at this stage to take partial assurance, absolutely recognising there's an awful lot of good work going on from the people team and colleagues across the organisation. But again, as we've discussed in this meeting, the workforce metrics are not where we would like them to be, and recognising that it didn't feel appropriate to take full assurance at this stage. But we absolutely appreciate and welcome all the good work that people are doing to address the issues. And I will probably stop there, Mary. Thank you.
Yeah, that's really helpful. And again, the report was comprehensive. So you have outlined the main things. And I note that you are escalating to the board our ongoing concern about the lack of progress of a system-wide strategy. You may not know the answer to that, but Alison might. Do we have any indicator as to when that might be available?
So there is ongoing discussion at the moment about creating a more detailed clinical strategy. The workforce strategy then can wrap around the direction. So, you know, if we are moving more services to be place-based, then, as I say, we need clarity to then look at then what the workforce implications are of that. So that's sort of the chicken and egg that we go around.
I understand that, Alison, and I certainly don't need to tell you what I'm about to say, but I guess what troubles me a little bit is in any change management progress, we do need to have pace, because otherwise people become very worried or things don't happen the way that we need them to be. So I guess I just perhaps note the need for pace on this, if we could. Isabel, were you indicating?
Yes, sorry, I couldn't work my buttons at the same time. I think just supporting what you've just said, Mary, in terms of thinking about that medium-term strategic direction for workforce, I think it's going to be really important to get clear indications about commissioning intentions and what changes are likely to take place, if any, in terms of our services in relation to place. And I think, secondly, then, in terms of our workforce strategy, we need to acknowledge any lead-in time if we're talking about redeployment or change of role for staff to be able to go through that change process. So I think there is an urgency for me about beginning to map that out and align it with our financial recovery plans as well. So I think that for me feels really important.
Thanks, Isabel, and including with our temporary hold on filling posts. The whole piece goes together, doesn't it? So, yeah, thank you. Anybody else like to ask Adam anything? Okay. Oh, Richard, I'm sorry.
Sorry, and it's probably pertinent to mention here, but it's probably for the next set of items. So where there has been partial assurance given for some of the items that are going to come next, can we just, in consideration of those items at that time, just briefly highlight whether the concerns of partial assurance at People and Culture Committee have been addressed in the latest iteration of those reports? Because it's hard not being part of the committee to follow that train through, but that would be useful if we could.
I think Alison might be able to pick that up. Yeah, is that all right, Adam? Yeah. Okay.
Could I just comment as well, if it's okay, Mary? I think the system workforce strategy is a really important point, Adam. And Alison, I'm very conscious that we are the largest part of the system from a workforce perspective. And you have the dual executive director role for workforce across CFT and RCHT. So I think we'd all want us to be really actively involved in developing what would be our system workforce strategy, working with ICB colleagues. I understand that that's an area of priority for the System Workforce Committee, but clearly we haven't yet got that. So it's just trying to think, how do we progress this? I don't think it can just sit with Patrick. I think this feels, Alison, that this is a joint executive responsibility with you and with Patrick in the provider and system workforce executive chief people officer roles, and whether we need to ask perhaps through you for you and Patrick to jointly agree the timeline for a workforce strategy. I think it is urgent. I think in some respects we almost need to see that in outline when we have the commissioning intentions in October, so that we can start to progress with that. And I appreciate that's a very short timeline, but we've had some very strong indications, I think, from NHS England nationally that there is no additional funding for this year. There is no additional funding for next year. I think ICB colleagues have given some indications we should expect a flat cash settlement as all providers going into next year. So I think we can describe what the financial environment looks like, at least for the next 18 months. And we do know the key areas of clinical transformation. So that feels like that's enough of a basis to be starting to outline what that workforce strategy could look like, at least for the first half of that 3-year period. So I just wonder, Mary and Adam, whether there's an action to ask Alison in partnership with Patrick to develop that timeline and kind of come back and confirm that, yes, we can have an outline by October, or if not, what is that timeline for that to be developed?
Board, how are you feeling about that suggestion? Makes general sense. Yeah, that seems to be a really helpful suggestion, Adam. If you're happy with that, we could ask Alison to pick that up.
I absolutely understand the logic and the robustness of the suggestion, and I certainly will pick up with Alison. I would suggest, I think we'd all recognise that needs to be on a iterative basis. It will be quite high level, rough, for want of a better word, to start with, and it will improve and sophisticate over time. I'll absolutely pick up with Alison, recognising the pressures on her and her colleagues to deliver 24-25, but absolutely medium term is key here.
Okay, thank you very much. Then could we note Adam's report from the People and Culture Committee for July 24, and then move over to you, Alison, for the, well, whichever order in which you are going to take them, the following reports, please.
Thank you, Mary. So my intention is to go through report number 13.1, which is the Equality, Diversity and Inclusion Annual Report. In doing so, it will pick up 13.2, which is our Workforce Equality Standard, and 13.3, which is the Pay Gap Report. The reason being is those two reports are included within the annual report, but there is a statutory obligation to publish these reports separately. So, as I say, the EDI report is a statutory report to meet our legal obligations under the Equality Act and our Human Rights Act. This report pulls all the data from EDS, the Equality Delivery System, our workforce race equality, and also our disability equality standards and our pay gap report. I'm just going to go through at high level because I'm sure everybody's read the report, some key highlights. And so that is that we employ 73% women, but our pay gap has actually increased from 25% to 30%. This is also replicated in our lower bands. Our ethnic minority staff, and I'm using the terms that are prescribed by NHS England, have increased from 8 to 11% of our workforce. So whilst there is improvement in our medical and our clinical ethnic minority staff, we have a lot more to do to ensure that our Gender for Change staff also come from a diverse background. Separately, we have more work to be done on disclosure rates. And I'm just going to also include, whilst we want everyone to complete their protected characteristics so that we're able to report accurately and to measure whether we are making progress in terms of who we are promoting, who we are recruiting, who we are shortlisting, etc., who we are training, you know, what are those staff experience outcomes. That's why those data protection characteristics are really important. The other area that I'd just like to flag, because we've had an incident very recently, is also an ESR. Can people make sure that their next of kin is also updated? It's really helpful when we have an incident that we have to work with quite quickly. So I'll come back to the report now. Bullying and harassment is good. It's down from 33 to 26%. However, we are still more likely to appoint white consultants than from a colleague from an ethnic minority background. I note on the Equality Standards report, actually, that has not been corrected. So I apologise, that is not the latest in that particular report. Bank workers as well, if any bank workers are listening today, again, really need your help in ensuring that all protected characteristics are reported. And we are also seeing a trend that our bank workers are not as treated as favourably as substantive staff. On disability, staff numbers have increased. On our workforce sexuality ratios, we can see that the numbers of staff from an LGBTQ plus background have increased to 13%. So that is good news. Numbers of staff who are asking for support, particularly on transgender and EDI awareness training, has increased, and it's coming from a good place in terms of wanting to know how to improve the patient experience. We had our first Diversity Celebrating Diversity conference this year. That was an area where we focused on race. We know that recent events which have led to the solidarity listening events led by Steve and Debbie as chief execs also tell us that we still have a lot more work to do in this area. Just on the pay gap as well, just to touch on a couple of highlights. As I said a few minutes ago, our mean gap has actually increased. That is not a good news story. In fact, we've decreased from our rates from 2020 by 4%. So although women hold 59% of the highest paid roles, equally 69% of women hold the lowest paid roles, and there's something that's happening when staff are promoted, that, to say, as well as recruitment, that we're not making the inroads that we should be on reducing the gender pay gap. International recruitment has certainly supported us in terms of, particularly in the medical workforce, those colleagues more likely to earn more than those from a non-ethnic minority background. Section 5 within the pay gap report indicates the actions that we need to take to reduce the pay gap, as well as within the report more generally in the annual report of areas where we need to support staff in reducing discrimination from all protected characteristics. Thank you.
Thank you, Alison. You've covered a huge amount of ground there. Colleagues, are there points that you would like to pick up with Alison? Robin.
Really interesting, important report to read. I have to say I had to go through it a few times because I did get a bit muddled as to what some of the things were actually trying to tell me, and think, is that number a good number or a bad number? The thing that really struck me though was the amount of gaps we've got in our knowledge from the first instance, and you referenced that, Alison, but it makes me wonder how valid are the then analysis with the quantity of unknowns we've got declared in the first instance, because it's how we can then really get underneath what is this telling and what are our meaningful actions and tracking it. I felt reading this that our goal number one needs to be resolving why don't people feel confident to declare into the ESR, and I thought a lot about coming right back to say, actually, do we have a space first to get into, say, what are the barriers for people not declaring, and do we need to then tackle that bit first, because that might also give us some clues to some of the threads that then weave their way through this report.
Alison, do you have any thoughts on Rob's suggestion?
I really support that, because the data that we provide and the analysis is only as good as the data that we hold. And I know I feel like a bit like a stuck record now over the past couple of years about, please, colleagues, complete your protected characteristics, but also I've added in now, please complete your next of kin too, because it is really important for us to be able to do that work, to actually see whether or not we are improving. And we can see on the pay gap at the moment, it looks like we haven't improved. In fact, we've gone backwards. So yeah, it's a big plead. So thank you, Robin, for making that point.
Is that something we would be able to action? Or how would we be able to action?
So we've got some comms. We've got some comms that's almost ready to go, working with Lindsay, actually. But, you know, I suppose I need every leader in every area to remind staff, you know, to give them 2 minutes to log on to ESR and to just make sure that field, and I know it's not the nicest system, it's a national system. We'll probably get a new HR system sort of late 2030 probably, by the time we've done a national rollout. So I do appreciate it is a bit clunky, but it's the only one national system we've got, so we've got to use it.
Do you think people don't know what the protected characteristics are sufficiently do they, clearly when it's very obvious they will know, but I wonder whether people, what the reluctance is caused by. But
I
think
know
that's-
historically, particularly around disability, people have worried that by declaring their disability, would that mean that they would be offered the role? But actually, we've been improving in that area. And I think people really do understand now that you come and work at the NHS and, we will make reasonable adjustments to support staff in the workplace. I think that message is now out there. I probably think it's to do with a lot of other things in terms of it gets deprioritized in terms of your to-do list.
Yeah.
It's not the highest thing.
Thanks, Alison. I've got Kim and then Richard.
Just on that specific point. Yeah, I suppose what tends to happen if an individual thinks that the recruitment process has been good and accessible and inclusive, then of course they're more likely to register, disclose their protected characteristics. And what we've seen in other organisations is that newer staff are more likely to disclose because of the changes we've made to recruitment. And that might provide, so that will mean more people are reporting, so that will get your numbers up, but also that does have an impact in teams and encourages other staff to do so. So that's the usual trend.
That's really helpful. Thank you very much. I've got a lot of people want to speak. Is it on that point? Right.
You go first, Kim.
I'll go after you.
Having been through kind of the induction process myself recently, I also wonder whether after the recruitment bit, whether there could be a bit more emphasis in the induction process as to why we're gathering this information, and also a little bit of training on how you enter it. So I believe I've entered all of mine on ESR, but I don't believe it's being captured in the report we have in front of us. So the other question, Alison, is how often are these reports updated? I joined in February. I would assume my records should be on there, but it's not reflected. So yeah, just those two bits on training and possibly induction.
More emphasis, yeah, really important. Thank you, Kim.
I think it's an historical. How do we socialise it? So are we discussing it even in appraisals and encouraging? I know lots of staff don't feel comfortable filling in some of this in fear that it might jeopardise. And it shouldn't. It comes to freedom to speak up, isn't it? How are we socialising it? If we see a report that reflects even the board don't report, what encouragement does that give others to come forward? And unfortunately, some people have lived experience where they have declared something and then landed up in a sickness and absence management. So how do we separate the two for reasonable adjustments? Yes, you can declare. We have reasonable adjustments. We're educating our managers and leaders, and we encourage that openness to be able to support you. And I think that played out quite largely across RCHT and other organisations for neurodiversity, for example, where people declared that and then weren't able to get the equipment or the support they needed. So I think we've got some cultural work in education to do here.
Thank you. I've got a lot of people waiting to speak, which is great. Ian, you first.
Thank you. Yeah. So I had a comment and then a thought, really. So my comment was I couldn't work out from the paper, Alison, what consultation had gone on through this with our staff networks and to what extent they were involved in it. So I appreciate the data is from specific data sources and systems, but I couldn't see on its journey how well connected with it and consulted on it our staff networks would feel. And then my kind of observation based on some of that discussion, and particularly when I was thinking about the gender pay gap deterioration, we use language, interestingly, and I guess I'm challenging all of us, we use language that RCHT is not an outlier in this data when you compare us with others in health sector. But it might be a development session for board to consider in terms of how do we lead in these areas, because they are so important, and lots of industries that were traditionally a particular gender don't have that anymore, and I think we've got a pivotal role to play in that personally.
A really helpful suggestion, Ian. Thank you, Alison. I'm sure you're taking note. Alistair.
Two things, if I may. The first one, relatively short, and a suggestion is, I think I potentially understand the reticence of people to declare some of their protected characteristics when they're coming for interview or initially in a job. But later, once you're in an organisation and understand what that organisation is and does, and the culture of that, it will potentially become much easier to do that. So just a really good example of how we enter things into ESR. Lindsay every year reminds us to do our declarations of interest. Do we every year go to our staff and say, please update your ESR, please update your, if you have protected characteristics, please enter them because it helps us with, etc. So that was the first thing. The second thing was I'd really welcome Alison, and I've talked to our ethnic minority network chair about this, is a bit of a look at your comments about consultant roles and white candidates. I think that it's it's not a very specific comment. Then it doesn't allow us to understand what that means. So I think I know from some of the data that I've seen that we potentially, for consultants, we're less likely to shortlist people, but when somebody from an ethnic minority comes to interview, they're actually more likely to be appointed than another candidate. So I think there's something about our interview processes, something about the way that interviews and job descriptions are set up that we could look at to make them as inclusive as possible. And I know that Mary and I have talked about this, and we wanted to chat to you about it as well. So I think a deep dive into that recruitment process and whether we've got any institutional bias problems would be really useful.
Indeed, Alistair, and we have got that meeting pending, which will be very important to have. Thank you. Steve.
Yeah, I welcome the report, Alison. It's very clear. It's also very troubling as well. The gender pay gap decreasing from what was already, in my view, a completely unacceptable position of 25% to about 30% is very concerning. The race pay gap, we don't have a previous year comparison, so we can't say whether that's worsening or improving, but whatever it is, at just over 12%, that appears to be in no way acceptable either. And I don't think we can resolve the actions that would address that here. I'm sure the staff feeling safe and supported to make a declaration as part of it, but there'll be a lot more to it than that. So I was just wondering, Alison, whether we as a board say we must address that. We must address those two gaps. And that's the thing that we consider here. And then there is some work to be done with colleagues across our organisation and with external expertise about, to take Ian's kind of comment, in those sectors that have been able to radically address this, how they've done it, and then what does that mean for the actions that we take? And then we hold ourselves to account in a year's time on wanting to see those two indicators particularly have improved.
Yeah, that's really helpful, Steve, because I just think that this is a more general comment, it's not just on, but unless as a board we really make this whole topic a high priority, it isn't going to happen. And it seems to me, and certainly sitting in the solidarity events and other things, this is a live topic that is not being done well in our trust as well as it should be at the moment. And I think we've just got to determine as a board to, maybe it's a resource issue, but whatever we need to do to just say, can we stop having annual reports that say these things to us and get on and make a change, a measurable change, as you've just said, Steve. So I'm seeing sort of noddishes, not nods, actually. I'm seeing nods now. Okay. Where are we? Richard.
Yeah, I very much agree with what you've just said. It's about talking at a governance level and then talking again and again. And it's really important to do so. My point was about gender pay gap and flexible working. And there's a number of reasons raising that. One is just about whether in our job ads we talk about appropriate flexible roles, and then in practice where we look at flexibility at the individual, team and organisational level. And I'm in part asking it because there might be a link between Freedom to Speak Up and how it lands a request for flexible working. at a local level, and also from a government perspective, where people will be able to ask for flexible working at day one. Just are we in line with that and ahead of the game? But it's around that gender pay gap that I'm concerned about.
Alison, do you want to respond?
Sorry, we've recently introduced
I think you might. We can't hear you.
Sorry. Hello, is that okay?
Yep.
Richard, thank you for that. And thank you for all the comments as well. Really support that, sort of really focusing in on a couple of areas, because it's such a massive area to try and move all of the metrics. So really welcome those suggestions on targeting. But on the flexible piece, Richard, we've recently introduced some new guidelines and promotion around flexible working. The other thing I think this also relates back to is all the work that we're trying to do within our OD programme as well. So there's another link back to staff going to those sessions that the OD team are running.
Thank you, Alison. Ella?
Yeah, I have a couple of points, but in the pay gap actions in section 3, so I think it speaks to what other colleagues have just been saying. I think we ought to be more ambitious. So a 2% improvement by April 2027 doesn't feel like it hits the mark for me in regards of being ambitious on this. And then secondly, on the third bullet point, it puts the onus on the person applying for the job, which is right that we should support them and develop people where we can, particularly internal candidates. But I think we also need to say for the people sat on the panel, what's their responsibility in this? And the onus shouldn't be on the people who are being discriminated against necessarily here. Yes, we have a responsibility to help develop them and give them equal opportunities, but we also need to develop our leaders and the people who are making the decisions and put the onus on them.
Really helpful.
Yeah, thank you, Ella.
Ella, thank you very much. Adam?
Thank you. I was just going back to Steve's really helpful suggestion for us as a board, and maybe stating the obvious, but I'd envisage that the People and Culture Committee would oversee the action plans to address all of these issues and report back through the assurance report on how we're progressing, and then we'd review it in a year's time as a board in terms of how we're doing or not doing against those action plans.
Yeah, that's entirely appropriate. I just think there's some suggestions around the room from Ella just now and others that we raise the ambition here.
Comment.
Richard?
And just on that theme, and I'm sorry, I might be missing it in the papers and in the discussion, but have we evaluated last year's plan? So we did this last year, didn't we? We looked at the figures and we put a plan forward to drive more inclusivity, more diversity, etc. I'm not really seeing how we've evaluated last year's plan that would explain the figures that we're seeing now, and whether there are things that we should learn from that in terms of either our ability to implement a plan or the fundamentals that underpin the plan. So,
Alison,
and apologies if I've missed that.
No, it's a fair question. Alison, are you able to respond?
So just over a year ago, we had no resources in EDI. So I think it's a good question around how much progress have we made in a year. We could certainly do that work to try and look at the track changes, but we know this is something that does take time. So I really welcome those suggestions on let's choose those 2 targeted interventions and see if we can get a step change on those 2 rather than trying doing everything all of the time.
It might be a really good idea to test with the staff networks as to whether those are the right 2. I mean, that's a board view, but it would be really important to get that view. And I know, Ian, you wanted to come back in, didn't you, perhaps on that point?
Yeah, just I'm conscious I did 2 questions in one. So just on that consultation with staff networks in terms of this document, Alison.
So In terms of the annual report, this doesn't have consultation beforehand. Where we do consultation beforehand is on the equality delivery system. That is very much consulted, and those stories come through, which is a separate annual account on EDI. We also provide assurance quarterly through the People and Culture Committee and consult the staff networks on the quarterly report as well.
I guess my challenge would be why wouldn't we share it with our staff network? So appreciate we might not have done in the past, and it might not need their approval as such in terms of that process, but it might helpfully get some useful input, as kind of you're alluding to, I think, Mara.
Yeah,
yeah.
If I could just comment, coming back to Adam's comment, Adam, I thought your reflections about the role of people and culture is absolutely right. And so whether we should think about agreeing the annual report, that is a statement of this is where we are currently, firstly. Secondly, support the areas of priority that are already identified in the report, but ask People and Culture Committee with Alison to look again at the level of expected or improvement for the next 12 months. Ella's made the comment about is the level of ambition right? I don't know whether we could do this, Adam and Alison, but I think if we're able to say it's our ambition to eliminate the gender pay gap and to eliminate the race pay gap over the course of the next 5 years, I don't know if that's the right timescale. It might not be, it might need to be longer, but that's our intent. And for the next 12 months, the areas we're going to focus on are these, and we think that would have this incremental impact. And I don't know whether we've thought of that longer term timeline about what's necessary to eliminate that. But whether we ask People and Culture Committee to take an action to refine the level of ambition for the next 12 months.
I think that'd be a really good suggestion. Adam, are you happy with that?
Yeah, I'm happy with that.
Okay. Yeah. Okay, so let's do that. Are there any other questions on any of the other matters that have been covered? If not, I'll go over the need for the approvals. Okay, so on the annual equality report, we're asked to approve the report for publishing in line with the Equality Act, public sector equality duty requirements. On the workforce equality statement report, we're asked to approve for publishing NHS England's requirement to publish workforce race equality standard and workforce disability equality standard reports. And on the pay gap, gender and race report, we're asked to approve for publishing in line with the Equality Act, public sector requirements, to publish that report, noting the gender and race bonus pay data is not included at this time and not currently available, and that would be the reason. So if we could make those approvals, but also note that we are asking through People and Culture Committee that an appropriate ambition is set and monitored for the overall topic. Thank you. Which then brings us to Remuneration Appointments Committee. Oh, did I miss it? How could I have done that? I apologise. 13.4, Board Diversity Plan. Lindsay.
Thank you, Chair. So the Board Diversity Plan is presented. It's a requirement to have a Board Diversity Plan within the NHS People Plan. The plan was approved this time last year. The Board Diversity Plan is deliberately focused on improving diversity across the Board of Directors and its senior staff, and recognises that diversity is actually a governance issue. The Trust's broader approach to equality, diversity and inclusion is set out within the Trust strategy and within our annual report, EDI annual report. The report gives an update on the 23-24 plan, noting that 2 of the 6 actions were complete as approved at the last board meeting, and that the remaining 4 actions are in progress. But
we've lost the screen.
To the 24-25. There are 5 new actions set out within the 24-25 plan. they're obviously in addition to the ones that we are recommending that are transferred across. Just to draw attention to board members' attention is that we acknowledged in the 23-24 plan that we would have an ambition to ensure that over 10% of our board of directors and senior managers were from BME backgrounds by 2025. Obviously, we're soon coming towards that. However, we recognise that this was a stretch target, and it's actually we haven't been able to achieve that. It still remains to be an ambition, but colleagues will see from the data provided in the report that actually we can numbers of very senior managers and band 8Cs and above actually decreased from 5.9% in 2022 to 1.01% as of June of this year. It's recommended that the 4 actions from that plan move over into the new plan, and I won't go into detail, but there are 5 areas where we look to try to improve our training around EDI, particularly especially around Oliver McGowan training, improve our the visibility at board as well through having EDI and staff and patient-related stories at board. Embedding some processes that we all implemented last year around the triple aim. Actually, I think we could do a lot better. So I think we'd all recognise that we can do that. So some actions around how we can improve that, as well as continue our engagement with the Next Director programme. Colleagues will really warmly welcomed Esma Bozai to our board earlier this year, and it's been fantastic having Esma on our board, and we're looking to try and actually improve that again this coming year. And the last would be around improving our links with our community networks. So obviously, as we talked about, we have our own EDI network leads, but I think there's more we can do, I think, to engage our local communities. So the plan was presented to People and Culture Committee and was recommended to the board for approval. So it's presented here for the board to provide comments and approve, please. Thank you.
Thank you, and I'm sorry for overlooking you. Are there comments or questions for Lindsay? Sorry, I just missed who that was. Richard.
I just wanted to comment on the over 10% target, because it's interesting to hear that we've gone backwards. I think it's really important to have an ambition to increase the representation from ethnic minority of staff from a minority ethnic background. I'm not sure about having a target of over 10%. I think it's a bit of a double-edged sword, because one, we're not achieving it. In fact, we've gone backwards, and I'm not sure it sends out the right message either in terms of it's a bit of a double-edged sword for everyone, I think, ethnic minority staff and recruiters. So I would prefer that we didn't have that over 10%, but have a very firm commitment that we monitor to increase representation.
Any thoughts on that, colleagues?
I think it's a challenging area as to whether or not to have a target. I think part of the argument that might argue in favour of it is that becomes something that we can be clear about. Are we achieving that or not? Part of the potential additional challenge is the community across Cornwall and the Isles of Scilly has a much lower level of black and minority ethnic people within the community, according to the latest census data, a much higher proportion within RCHT's workforce. And so then there's something about what should we say about the composition of the board to reflect the composition of RCHT's workforce. Now, none of that necessarily argues that 10% is a right figure to have if there is a target or not. There would be some disadvantages to not having a target in terms of being able to show and evidence our ambition. But even if we have a target, the challenge about how you'd set that, I think, is difficult.
I wonder whether we need further discussion about this, perhaps at People Culture Committee, because I think it's a really important point to have raised, Richard, and I think it needs a bit more hearing and rehearsing of the arguments. Is that okay if we did that? But perhaps, Adam, if it's all right with you, perhaps at the next one, because I'm just aware of pace on all these things, and if we don't just get on with it, we won't. So we are asked currently to approve the
Sorry, the person wanted to
Oh, Alison, you did. I had you written down.
Yeah, just on that thing, I welcome further discussion at People and Culture, if that's okay with Adam. For me, I think there's something about setting incremental stretch rather than just having a big leap, but we can have that conversation at the committee. And then on the second point around the extending to community, we've been meeting since the solidarity events with community leaders. So I just wanted staff to be aware of that, particularly in light of all the issues that were raised during those sessions. Thank you.
Thank you, Alison. Steve?
So just to come back firstly, if I can briefly, to the 10% target proposition, that is framed for the board of directors. So it may be we want this to go to our People and Culture Committee for consideration, but it's a board of directors plan. So if it does come there, not everybody would have the chance to kind of input and comment. That still might be the right approach, but I'm just mindful this is a board document. The separate thing I was going to raise though is, as a board, it clearly sets out in the report that we are not recording in ESR whether we have a disability. We're not recording ethnicity in ESR. We were having a conversation earlier on, weren't we, about the importance of encouraging colleagues across the organisation to do that. So I don't think we should kind of shy away from that. That's very, very clear. So I don't know what our obstacles are to that, but if there is anything we need to do as a board to help colleagues feel it's accessible to make that declaration, or whether there's anything we need to do around it, it'd be very helpful to get any views if there's anything else we need to do, so we can move to everybody on the board having made the ESR declarations.
I think on that, Steve, I would actually support what Usma has said, because when I looked at the figures, I didn't recognise that all the data had been taken into account. So I wonder whether we could just check how that gets translated through from ESR into our data, Usma?
Or even in our next private session, just have a little run through for all the board members of this is where the data should be, and then we're sure that it's actually the issue is it's not pulling across rather than we haven't entered it.
We didn't ask all protected characteristics at board level.
So that's really helpful as well. And I was looking to two examples that were quoted in the report about disability and about ethnicity. And then importantly, are we asking the appropriate set of protected characteristic questions? So that's useful as well.
Yeah, so in relation to the 10%, I think in the report it states that our workforce is at 3%, only 3%, but actually in our IPR, it's nearly 12% now. So it feels like 10% wouldn't be out of kilter with that, and we ought to be saying that our board does reflect our general workforce. I just thought I'd raise that because I think in the report it does state 3%, which feels like a big difference to 10%.
Go into this too much, but there's a huge piece of work to do, which I have done in other places, around recruitment to board positions, around how we inform people, how we educate people, how we enable people to feel that they could come forward. And I've done a lot of work on this in Wales to good effect, actually, but we don't do yet that piece of work, and perhaps it's a piece to do with colleagues, council and ICB and CFT, that some of the proactive work I've done in other places is absolutely canvassing for, offering training for both interview process and governance. So I think there's a piece behind this, which is, you know me, despite my very best efforts, I still haven't done very well in all these years. And it is about who applies. And therefore we've got to change that too. So maybe that's another thought that could get put into the thinking hat pot, Adam, when you talk about it. But I take your point, Steve, that specifically is different what we're talking about the board in this paper or the general point, but they do overlap. Alison, and then Ian.
Yeah,
then-
I think, as I said, I'd welcome a separate board discussion around this, because agree there is possibly a lot more that we could do if we put our collective minds together. The separate thing is just from my team's perspective, they would be very happy to do a session if anybody's uncomfortable around how do I complete the ESR, because I know colleagues on the board won't be using ESR very regularly. Thank you.
Thank you, Alison. Ian, and then Uzma, I think. Ian.
Yeah, mine was just when we get to the recommendation, if I can, Chair, I just wanted to clarify. So I think it's saying approve the transfer of the 4 remaining actions. I think it means from the 23-24 into the 24-25 plan, but it says to the 23-24.
Yes.
So, yes, I think I was just checking my understanding is the 4 that we're carrying forward from last year's plan are going alongside the new ones. Yeah.
Correct.
Helpful. Thank you.
Thank you for pointing that out. Uzma.
I'm happy to continue the discussion, people.
Okay. Okay. Any more? Thank you for that discussion. Really, really valuable. So we're asked to approve the transfer of the 4 remaining actions from the 23-24 diversity plan into the 24-25 diversity plan, to approve the 24-25 plan, and to ask People and Culture Committee to have a bit more of a deep dive into the matters that we've been discussing this afternoon. Thank you. Having set you up once, Alison, can I do that again now, please, to the Remuneration Appointments Committee report?
Or Isabel?
Oh, God.
I'm quite happy for Alison to do it, but no, I think it's me, and I will keep this very brief, as the report is very brief. And that, I think, just echoes the nature of the Remuneration and Appointments Committee, where a lot of the issues relate to individuals, which, of course, we would not be reporting back on in a public forum. So, so the agenda and the nature of the items are predominantly fairly confidential. However, what we're very happy to share in public is the key agenda items that we discussed, which form into 3 areas, really. The first of which is that we received an update on our executive director and VSM recruitment, very senior manager recruitment and appointments. And that includes a process to appoint a new chief medical officer and a chief finance officer who is now with us. So congratulations. So I think that's the first part of it. The second thing that we did was, and again, it probably relates back to some of our earlier discussion around EDI and the board, but we received the outcomes of an annual board skills survey, which was conducted to identify where the board might have areas of development. And that might be pertinent in terms of our previous conversation, as well as the strengths that we have as a board, which can be then fed into the design around future board development sessions. So I think that's a really important piece of work that we do annually, which Lindsay then reports back to us on. So thank you for the work that you do on that, Lindsay. And then finally, as a Remuneration and Appointments Committee, we receive annual information about the Executive Director's annual appraisal process and signing up to a set of objectives for each of them to deliver over the course of the coming year. So we have gone through and reviewed and approved all the proposed appraisal process and targets, objectives. So those were the 3 main areas that we've covered through that committee.
Really helpful. Thank you very much. What shall I call you now?
That'll do.
Jane, perhaps. Okay, thank you for that report. Are there any thoughts or questions on Isabel's report? No, thank you. In that case, we are asked to note the assurance report. And that brings us to item 15, which is the Charitable Funds Committee Assurance Report, which we, if I could remind us, are considering in our capacity as corporate trustee. So over to Richard, please.
And again, I'll be brief. The element that's partly assured is the family appeal. So we're looking for accommodation for families as part of the family appeal. And we did an options appraisal earlier this year. The costs were high, too high. And so we revisited this. and we're looking at a range of options which will be discussed at next week's Charitable Funds Committee on the 11th of September, where we'll hopefully have a final options appraisal and a new business case and a recommendation on how to proceed. I think we felt it's important that we meet need, but also offer good value for money from a capital perspective. And at the same time, we have received significant funding from the Elwyn Thomas Memorial Fund, who, because of good stewardship from Alison's team, have been appraised of the current situation and the need to look at alternative accommodation options. So when we do have a final options appraisal, that will be the recommendation will be brought back to the Trust Board.
That's really helpful. Thank you. Colleagues, are there any questions for Richard? No. And again, maybe I'm kind of stuck on pace today for some reason, but have we got any kind of view of the general pace of that once we've got the options? Because this has been around for a long time, and I know members of the public will be very interested in that.
I think the pace will be based on which option we choose, to be honest, and we'll know more next week. I'm looking at Ian and Alison for.
Yeah, I think that's a fair assessment, Richard.
Depends on what we do. Okay, thank you. Thank you. Let's note then, please, the Charitable Funds Assurance Report and move on to the Audit and Risk Committee Assurance Report. Adam, please.
Okay, thank you. So page 547 in our pack, 3 items for board in particular to note, and then I'll mention 2 other items as well. 3 items are on page 547. So first is to bring to board's attention that we discussed at some length. So audit committee, we deliberately looked to set the internal audit work programme amongst other criteria using areas that we're concerned about across the trust. So we looked at loan working arrangements as an area where we suspected there was concern. Internal audit did a review and has identified and taken limited assurance in terms of loan working arrangements. At the time of the July audit committee, we were struggling as a trust to produce a definitive action plan because it cut across everyone and everything. So we wanted to raise that for the attention of board. Subsequent to the July audit committee, there is now a definitive action plan to address the issues raised. And having checked with internal audit during the course of this meeting, those issues are progressively being addressed. And that's the first issue to bring to your attention. Just before the July audit committee, I was informed as chair of the committee of a breach of standing orders, which we discussed verbally during the meeting. And the issue was appropriately highlighted, and the issue has been addressed, and learning points from that will come back to the October audit committee. And in this session of the board, we have discussed business cases from various different perspectives. At audit committee at the last meeting, we were discussing the concern about business cases that have been in the double lock or triple lock process that Steve, as chief exec, referenced earlier. And they've been in that process for a number of months. And how are we as a trust ensuring that we're still taking appropriate action whilst we're awaiting an outcome from the triple lock process? And we were concerned that that was a potential weakness. And the example business case, it's not to say it's the only one, the example business case that we were discussing at the July audit committee was to do with looked after children. 2 other items to bring to the board's attention. One is mentioned in the paper, but just to remind or bring to people's attention that there is a piece of work going on that's being commissioned nationally for all trusts, and our internal audit service are doing it for us and CFT simultaneously, which is looking at workforce controls. And we're expecting the outcome of that review by the end of September. And then we'll have a level of assurance from our internal auditors as an independent judge as to the level of assurance we can take in terms of our workforce controls, which is obviously fundamental for the delivery of the workforce SIPs. And then the other item to mention, we've mentioned a lot the ongoing discussions we're having about improving our reporting of our SIPs. And we had the session yesterday or the day before discussing that from the perspective of finance and performance, quality assurance and workforce committee. We also discussed that from the perspective of Audit and Risk Committee, in particular in terms of our external auditors flagged in their last annual assessment for 23-24 a concern about the robustness of our medium-term financial plan and a concern about our ability to deliver SIPs. So it's important that we, in our considerations of SIPs for the future, make sure we address those concerns appropriately from the external auditor. And we discussed that well in the meeting we had in the last couple of days. And that's everything I wanted to raise.
Oh, that's really helpful. Thank you, Adam. Sounds like it was a really good meeting. Adrian.
Yeah, just to, I sit on audit and risk for CFT, who also use ASW. And we met yesterday, we had a meeting yesterday. So a couple of updates with regards to what you've said. The workforce one, although it is a national issue, it's been rolled out by region. So we're the first, one of the first regions to be doing it. It's not yet national. We're likely to be requesting an extension. I don't think the work will be done by the end of September. The request was by the 30th of September. They're now predicting potentially the middle of October. And this one was the one that I wanted really to flag to you, is that there's likely to be a second one being directed nationally stroke regionally on grip and control. So they're expecting that to land fairly shortly.
Thanks, Adrian. That's really helpful.
Well, thanks, Adrian. That's helpful. Ian.
Yeah, so I might just comment on, that's really helpful. On the second point you raised there around grip and control, that's being discussed with chief finance officers, because one of the impacts, so there is an ask regionally about our level of assurance as organisations on our grip and control. We undertook quite a big piece of work on that last year as a self-assessment, and we created an action plan which we followed up on, and that included things like the communication of our financial position, for example. Audit plans obviously have already been set for internal audit, and so part of the discussion that's been had with chief finance officers across the region is how we accommodate that request and how we get that assurance. It may not be yet through internal audit, so we'll update further at Finance and Performance Committee, probably is the appropriate next point on that one, but really helpful to raise it, Richard.
Thank you, Adrian. Alison?
So I was just going to comment in terms of the workforce audit, because it is such a large audit that actually both across RCHT and CFT, the HR and the finance teams work together in a new way in terms of collecting the data, and it has been commented on that we were further ahead in comparison to the other trusts in trying to help the audit team in getting the evidence that they required. So I just wanted to let board colleagues know that. And the second bit really is sort of further to what Ian was saying around where we're having new requirements coming in nationally for new audits. We've got a really, in both trusts, very tight audit plans. So there might be a requirement for audit committee to actually pause something else and move it into the following. Otherwise, we're going to find that our auditors run out of time to complete the work.
And how would we pick that up, Alison?
I would presume it would be something that audit committee could consider. Thank you.
Thank you. Adam?
I was just about to say what Alice just said, so thank you.
In CFT, at yesterday's meeting, the way ASW had addressed it in CFT was talking to execs with regards to releasing some audit days that were set against other audit. For instance, the new fit and proper persons test, they reduced the number of audit days for that, but that was presented to the audit committee for approval.
I guess that's why I asked my question, because I'm thinking it's really perhaps an exec function to then present to the committee. I don't know, Steve.
Yeah, I think that would be appropriate. I think Ian wanted to comment on that. I will raise a separate point.
Yeah, so I meet in my role. I meet with internal audit on a monthly basis, and we update on the internal audit action plan. They then present that at the Monday exec meetings before it would come through to an audit and risk assurance committee. So that would be the process. Yeah.
Thank you for that. Okay, so with this report, Steve.
Yeah, I just wanted to, the third item that Adam raised, the business case is not being progressed to ensure that we have a way forward with regard to that. So can I just check, Ian, maybe looking to you in the first instance, but it might be Kim, Alison or other colleagues want to comment. Would it be appropriate for us to bring something back to the board which sets out definitively what is happening on those 5 business cases? They're clearly, we're all aware the funding position is a very challenging one, but nevertheless, each of those 5 business cases had a case and a proposition that board supported. So I know there's work underway with our executive and operational teams on each of those 5 areas. Would it be an appropriate next step for something to come back to board setting out definitively the position on those? Now that might be alternative mitigations have been put in place to mitigate the issue, therefore the business case is withdrawn, or funding is still required, and here's the proposition for it to be funded.
No, I'm trying to think which meeting I was in yesterday. So we had our triple lock meeting this week, and I chaired as one of the clinical execs there. So what we've asked for is for the action log to come back with all of the open actions on, a list of the business cases that have gone through the double lock and the triple lock program, and then we'd be able to have a definitive discussion that says, as a system, this is what can and cannot be supported, which will further help us with the mitigation we've taken to date, what further mitigation we need to take, and of course, what we're going to prioritise as we run through our financial programme.
That's really helpful. So that sounds like perhaps through my chief executive's report or through a separate agenda item, we could bring something back to boards to have that clarity. So if I could just check with Adam if that helps to resolve that aspect.
It would do, thank you. And I should have said, subsequent to audit committee, I've had further conversations with Kim and Ian in terms of the specific business case. And as Kim's outlined, there are discussions ongoing, and the suggestion was it could get slotted into your chief exec's report as and when. But that coming to the next meeting, I think would be helpful in terms of where are we with all of the outstanding issues. That'd be really helpful.
Could I, sorry for just testing this, the board paper talked about a concern over a lack of grip and control. Just to test whether by that we mean the lack of a resolution to 5 significant business cases, and the grip and control refers to the business case process, or is it a concern about financial grip and control? Because that would have a different sort of connotation. So just to understand, I'd understood it was about a lack of resolution and outcome from what's been quite a long, extended business case process.
This one was to do with, I think it tracked back to something like February, that it was first discussed at audit committee, that there's a resource pressure on RCHT around looked after children. And the response at that stage was, there's a business case in the system that's being considered under the double lock process. By July, it was still in the system being considered by the double lock process, and there was no other solution from an RCHT perspective. So that didn't feel like we weren't addressing the issue as an organisation until such time as it was addressed somewhere else. And in the meantime, we've got presumably vulnerable children that need our services.
It's helpful. Okay, just look to Ian, given that, does that require us to do anything additionally from a grip and control perspective?
I don't think so. I think it's the discussion that Kim alluded to. I think it is a symptom of a difficult financial climate for a system level, but it's incumbent on all of us as board members to flag that and to address it. So I think what you're proposing, Steve, in terms of that update of what needs to happen, is there disinvestment opportunities to allow these investments to happen in a restrained financial environment, or what mitigations are we taking, and how are we making sure that if there are issues, how are they being appropriately escalated, so that we see them as a board.
And it would be really helpful for us to know so that we determine what we do about it, whether it's escalation or what we do. Okay, thank you. That's really helpful. So we're asked to note the report with the additional point of there being a consideration of all the matters that are currently outstanding, and that would come back up through board in the Chief Exec's report. Okay, thank you very much. Lindsay, you are next on the board assurance framework.
So the BAF is presented. The BAF is updated on a monthly basis through executive-led discussions, as well as discussed at our committee meeting and are updated following that. The changes are made on the BAF elements in track changes, so therefore it's for the ease of understanding. It was last approved at the July Trust Board meeting. I won't go through each and every change, just for, because that'll take us a long time, but the detail is listed within the report. It's note to all colleagues that the BAF reflects a lot of discussion around our operational financial challenges and the level of scrutiny at our committee meetings. There are a few new additions onto the BAF. Just highlight a couple of things. On BAF 1, which relates to quality of care, we had a really good discussion with our exec colleagues around how we describe the gap in assurance. It was determined that it was better to be described as a gap in the ability to deliver emergency access standard, because actually we recognise that we're progressing with a range of actions and there are mitigations in place, but actually the traction and pace is not being achieved, and many aspects of performance remain outstanding against desired targets. We also talked on BAF 2, which is around workforce, and included a gap in assurance relating to loan working, following the discussion at Audit and Risk Assurance Committee and noting the task and finish groups in place to follow it through. We also noted through BAF 3 a new action, sorry, that's to do with integration, a new action with regards to the development of our system and operational financial plan for 25-26 and the internal work that we're doing with colleagues across our system, so we can better plan for the next year. And then I think that's probably just helpful just to highlight that we in BAF 4, obviously this at the time of reporting, we were in a position where we hadn't had confirmation with regards to the industrial action. Obviously we've now had that, so we will update the BAF in that regard. If you're happy, Chair, I'm happy to take any questions on specific matters, but the recommendations clearly out. Clearly recommend a couple of closures and amalgamations of BAF elements and gaps in assurance. Thank you.
Thank you, Lindsay. Are there comments or questions for Lindsay? No, thank you. It's just that suggests that work has been done well by the executive group. Thank you. So we are asked to approve the closure of actions to address gaps in assurance. So BAF element 1, the proposed closure of gap in assurance 7 relating to cancer waiting times, noting the ongoing management through the Cancer Delivery Board and then through the Integrated Performance Report. To approve the closure of actions to address gaps in BAF 3, the proposed closure of action 6 relating to the completion of a system financial forecast and the mitigation of actions to feed into the regional assurance response by the 2nd of August, which was complete. And with regard to BAF element 2, approve the suggestion to amalgamate the gap in assurance 2 with the gap in assurance 1, as you have outlined, Lindsay. So thank you. If colleagues could indicate their approval or otherwise. Do we have Bernie back with us?
Yes, Mary.
Thank you. Got you. Wonderful. Thank you very much. The corporate risk register, please, Bernie.
Thanks. So this reflects the corporate risk register position through April and May 2024. It was reviewed at ARAC in July. There are 32 risks on the new corporate risk register. There were no new risks added during that period. There was one risk decreased in score, which is Euroking, which Kim reflected back in the maternity and neonatal safety reports earlier. That will come off the corporate risk register when the final fixes have been mitigated. There were 2 risks that were removed in April and 1 in May. That's in relation to paediatric medical staffing, diagnostics performance and backlogs, and also the progress that we've made in transitional care. There was a further detailed review in relation to risk 9048 in relation to ED overcrowding, and that is expected to come back to the risk group later this month. And I'm happy to take any questions.
Okay, thank you. Colleagues, how are we doing on questions? No? Okay.
All right.
Thank you, Adam.
So there's a positive and a negative here. So thank you, Bernie. So we've discussed this quite a lot at Audit and Risk Committee and discussed having a more clear, easier to digest version of this report to come through to Audit and Risk Committee and to board. And this paper reflects that. So thanks to colleagues for the work on this, because I think it is much more digestible. But that does mean it's easier to pick out what I think are issues, which is a good thing. But just to flag, if I'm understanding it correctly, the appendix to the report, which is the dashboard, the final column of the appendix, page 604 in our pack, gives us a date to achieve the target risk score for the 32 risks on the corporate risk register. And I think with the exception of one, all of them are in the past. And I did flag this at July Audit Committee. So if we can address that for the next iteration, that would be really appreciated. So we're clear what is our realistic future date by which we're aiming to achieve the risks that we're outlining, the risk level that we're aiming for, please.
Yeah, and that Aoife's picked that up in terms of that work from ARAC, which will be reflected back in a future report. Adam, so thank you.
Adam, I know what you do. You actually wait till my head is turned that way and then you raise your hand. I've caught you at it now, so I'm wise to it. So, Bernie, thank you.
Catch me as well.
Oh, well, there you go.
I'm doing it when you're looking at Adam, yeah. It's just the, you know, it was a comment on the same point because I think Aoife's done a fantastic job in pulling that dashboard together. And having discussed this and also discussing ARAC, it's the issue of it's really important for board to note when we predicted the score was going to change. And what this highlights is, as Adam's pointed out, in the vast majority, we haven't achieved the mitigations to adjust the risk by those dates. What really needs to happen also is the next date by which we're going to achieve that so that we can see what we tried to do before hasn't been as successful as we hoped it would be, and it hasn't moved it in the pace. And then where are we expecting it now with that level of appraisal to then be in a point where it will move so we can keep holding this document to account.
So where would that work lie, Bernie?
So that's it. That sits in the overall action that kind of was picked up at ARAC.
On that point, would you also need to look at the controls and the actions that you've put in place to try to achieve that, to check and balance that they're actually the right controls and the right actions that are going to make the difference?
Yeah, absolutely.
Yeah.
Well, I think you've put in a different way what I was going to say, exactly, because if there are so many, are we not quite getting it right at the outset?
That's the point, yeah.
Yeah. Okay. But you can turn that away. Take it away, Bernie. Thank you. So we're asked to note the one decrease in score. Note that 2 risks were removed in April 24, one in April, one in May. Note the work undertaken in relation to ED overcrowding, which is ongoing. Note the approval of the revised corporate risk register paperwork. And note the current position on the top rated risks on the register and the assurance against them. And note the action that Bernie is taking away to review that chart. Thank you. Item 16.3 is a starred item, which is the Audit Committee revised terms of reference. I haven't been noted of any questions, so we're invited to approve the proposed changes to the terms of reference, identified, as you can see, using track changes, and which were endorsed by the Audit and Risk Committee in their meeting in July. If we could approve, please. And then, Lindsay, we now come to the Governance Improvement Plan, the name of which is still under debate, I know. But anyway, what we've currently called that. Lindsay.
Yeah. So our first the Trust first developed a governance improvement plan back in 21-22, and since then we have determined that we actually will have one every year to build on and sustain our enhancements to good corporate governance, efficiencies, effectiveness, etc. We did have a really good discussion at our board developments, our last board meeting. Actually, no, I'm not saying that right. It was a meeting a couple of months ago, back in June, where we had a really good debate about a proposed set of areas of focus and considerations for this year's plan. And so very much welcome colleagues' feedback for that. And actually, we did talk about the fact that should we call it a governance improvement plan, or should it be more of a continuous plan or something like that? So I think it's understood under debate. However, we've proceeded as we have done over the last few years. The presented is the 24-25 plan, and as set out in the report, we have used a number of outputs from board evaluation, and annual committee evaluations, etc., to try and pull this together. The plan sets out 14 actions, which are grouped into 7 areas with various target dates for completion. And also, we note that there is a transfer across of a couple of actions from the previous plan. I won't go into too much detail, but the areas of focus around embedding that executive governance structure, looking for continuous improvement around our corporate governance and enhancing the effectiveness of our meetings, ensure that we have the right structure in place. For example, the role of our transformation oversight group, and that's something Ella and I touching base recently. And then utilising benchmarking information. We had a board development session only recently where we looked to embed that and how we're going to report that through our committees. And the last 2 actions are around the development of a well-led review and our work in preparation for any well-led inspection, and the development of our partnership working arrangements. And board colleagues will have, obviously are aware, and it reported in Steve's report, is that we have agreed that a committee in common that we had with Cornwall Partnership and Foundation Trust, we're actually going to move to a different model where we have board-to-board meetings. So there are, in the report, it sets out where we've actually, how we're progressing against the actions. You'll see that we've already got a couple that are proposed complete, because we've made some good progress, and there's a couple not started. The board will receive updates through Steve's Chief Executive's report on an ongoing basis. And just in conclusion, it's presented for comments, and any feedback is most welcome. It'd be grateful if we could also approve the plan.
Thank you very much, Lindsay. And though it's a nice shortish paper, it does represent a great deal of work that goes on between you and your team throughout the year. Are there questions? Yes, Richard.
One point. This is in the context of being a newer NED, and the point is just generally around governance. Sometimes I feel on occasions we're presented with papers without necessarily all the context of previous discussions taken by the exec team, or the extent to which they've been discussed by individual committees. I think the benefits of being a unitary board, we see everything, but sometimes context is important, and sometimes I feel it makes it difficult to contribute without knowing what's been discussed previously. And I don't know if we can make that clearer as part of the cover sheet or summary that goes with the report.
In that consultation session, we've actually had that discussion about other committees and whether the previous reports that alluded to the matter, talked about it in the Remuneration Committee, haven't we, might be appended for setting a context. Don't know, Lindsay, your wisdom as a company secretary, what do you think?
Yeah, no, Richard and I had a conversation, because I think it's really important that within our covering report for all of our board and committee meetings, there is a section that's about context. It's actually about how we fill that in, and making sure that even though sometimes there's a short space of time between finance and performance and quality and committee and the board, we absolutely fill that template in and say, this is the matters that were discussed, these are the matters that were escalated, this is where the questions that were asked and concerns that were raised, and this is the actions that's been taken. So I think it's about how we use our existing template, but absolutely right, which is really, really good point, which is I don't think we're doing that as well as we can.
Thank you. Adam.
My hand's up, it's not intentional, sorry.
You need to. You're just trying to trick me.
It's keeping you on your toes. Yeah.
Okay, so we are asked to approve the 24-25 governance improvement plan, noting that it does include the transfer of 2 actions from 23-24. So if we could approve that, please. Brings us on again, Lindsay, to you on the board and committee dates. And I note that the ICB haven't yet developed their dates for 25-26. So you're having to manage that. Perhaps you'd like to tell us about it.
Thank you, Mary. So as per standing orders, the board is required to agree its schedule of meetings for the following year by the end of September. The schedule has been produced on the basis of our current arrangements and consistency and the timing of our meetings. We have engaged with Cornwall Partnership NHS Foundation Trust and the Integrated Care Board with regards to their dates, because also we, as everyone is aware, we have dual directors and an attendance across many of our committees. So therefore we have engaged them. CFT are in the process of reviewing their dates and taking their recommendation to the board. So as best as we can, we have tried to avoid any clashes. CFT, we have engaged with them and we will continue to work with them as they develop their dates. That's why the recommendation is that we note that the schedule of meetings will be reviewed again, and then any significant changes we'll let the board know. But we will do our utmost to ensure that our colleagues, we do not have any clashes and we align our meetings best we can.
Thank you for that. And I do note that there are some clashes with some ICB meetings that our colleagues can't get to because we've got committee meetings going on. Alison.
I think Ian was before me, so have you got your hand up, Ian?
Yeah, mine was just one for us to consider in terms of charitable funds committee. So I've noticed a couple of times, and it might be one that we want to pick up separately, Richard. So we've got it next week. It always feels like we come to board with it then almost imminently due, and it feels like then our board updates are not in sync. And in that important role as corporate trustee, I just wonder if there's something we could look at about whether we can schedule that, because it only meets bi-monthly as well, whether we could schedule that such that I feel that Richard and myself and Alison will be in a better position to give updates at board in a more timely way.
Otherwise there will be more delays. We'll be making decisions then waiting for the next board meeting.
Yeah,
absolutely.
no, thank you, Ian, because it has come up over the last year, actually, hasn't it? So, yes, if we could see what we could do about that. Then thank you, Alison, for giving away. Your turn now.
Thank you. Mine was on the ICB Workforce Committee. Tan, as the chair of the Workforce Committee, is committed to finding dates that I'm able to attend, given the board to board on Monday, which the chair of the ICB made it quite clear about the importance of that committee. Just felt it was important that that work that I know Lindsay is doing to try and ensure no clashes actually comes to fruition. Thank you.
Thank you. And you'll let us know as soon as possible, Lindsay, because clearly people's diaries get clogged up, don't you? So we've discussed and agreed the board and committee schedule 25-26, noting the variables. We've noted the schedule of meetings will be reviewed again to consider any change or addition in line with partner system meetings. Thank you. Item 19 is a starred item, so there's no discussion unless anybody had requested, which they haven't. So we're actually to ask to note the decision taken by e-governance to appoint Adrian Davis to the Finance Performance Committee. And Lindsay, the consideration of risk.
Thank you. I welcome, obviously, colleagues' comments as well. We've talked heavily around our financial and our operational challenges and the ongoing financial risks, which I think is currently accurately reflected in our BAF, but very happy to obviously continue to review that on a regular basis with Ian and colleagues. We've talked around our operational performance metrics and some deterioration in them, but I think, again, we are picking that up through our routine discussions around BAF1 and our quality of care. We talked about industrial action. I mentioned it in the BAF item, which is obviously we've now received confirmation around the receipt of the industrial action monies. So we'll reflect that in the BAF. We talked about the risk around the women's and children's and the MOU, which is unknown, but again, that is reflected in the BAF and we'll continue to monitor that. And the other thing is that just, we've talked quite a lot today around our gender pay gap and just maybe whether or not we need to consider any further risks or mitigations that, that fall out of that. So just to explore that maybe a little bit further.
Thank you. Anybody picked up anything extra to that? No? Okay, thank you, Lindsay, for that summary, which you can note in the BAF. And that brings us to questions from members of the public. So thank you for sticking with us till we got to this point. As I said at the beginning of the meeting, I will invite our company secretary to read out any questions from members of the public, and then we will ask the relevant director to respond. So, Lindsay, if we could have, I think, 5 questions, is it?
Yeah, we've got 6 questions in total, thank you. So thank you very much to everyone who has actively engaged in the meeting today and raising their questions. I'll go through them in turn. So Dr. Jane Burnell has raised 2 questions. For question 1, have there been any exchanges with the incoming government about the plans for the new Women's and Children's Unit? So I'm going to ask him to comment on that one.
Has been, and we recently had a meeting with 3 of the incoming ministers for Cornwall and the Isles of Scilly, and Isabel.
MPs.
Yeah, MPs, that's it, thank you. Isabel was with us, and that there is, it is on their agenda to speak to the minister about, and very supportive.
The second question from Jane is where NHS patients are referred out of area for out of area procedures, either because the procedure is not available in Cornwall or to shorten waiting times. Which specialist clinician has responsibility for monitoring their clinical status while they wait? What can be done to improve the way in which this is communicated to the patient and their GP? And I'm going to ask Rob to answer that question.
Yeah, of course, thank you. So if a patient is transferred to another provider, the responsibility transfers to that receiving clinician. We have, however, been working with our OCB colleagues on how we can support patients transferring to other providers. And what we've been doing is working to communicate with each individual patient on that.
So question 3 is from Andrew Albert. Andrew asks, can the board publish the criteria being used for the headcount reductions within the trust? I'm aware that the care groups are being advised on the number they are expected to shrink by, but there has been no explanation of how it is to be reached. And I'm going to ask Alison to comment on this.
Yeah, and thank you, Andrew, for the question. So it isn't a set criteria that we are applying in terms of achieving those pay cost reductions, and the numbers that have been set by Care Group are indicative of our month 1 position. We have a range of measures that we're asking care groups to consider, which includes looking at our existing vacancies, where we can do skill mix. We have our safer care processes in place. So there isn't a one size fits all, so that I can't give you a criteria that we are following. What we're asking our teams to do is to look at where they can make reductions, but also keeping an eye on quality and safety at the same time. So the care groups are being empowered to work that through. Thank you.
Thank you, Alison. Question 4 is from Holly Kiernan and relates to the National Pay Award. Holly asks, for staff who have left between April and October, will they receive back pay of the pay award, even if they are still not on the payroll? Alison, could you answer that? Thank you.
Yes, it's been our custom and practice to do that. So yes, thank you.
Alison. The 5th question is from Richard Raymond, and Richard asks, in the climate of reduced financial availability for the trust, Is the Trust aware of the increased costs of functions, for example, blood testing in off-the-site areas? He gives an example around the cost, etc., and suggests that we are spending money for reagents for tests, but there is no review of their appropriateness or awareness of the cost. And I'm going to ask Ian to provide a comment on that.
Yeah, thank you. And thank you, Richard, for your question. I think it helped answer part of our question earlier about are our staff aware of it. So it's really good to get a member of the staff asking a question around the financial climate that we're in. I'd refer back to the discussion I touched on earlier in terms of the review, improve and benefit work that we've been doing, and the ethos of that is to start those conversations. So we are aware of different areas and clinical support. I know as a care group are looking quite closely at, for example, the cost of blood testing, and that's partly come up through some of those conversations already because there's a sustainability angle to that we use plastic tubes to take blood samples in, and if they're not processed quickly enough we repeat them. So that's almost the core of what we're trying to get teams to do. So I don't think we're aware of all of them in answer to Richard's question, but I think we're on that journey, so really welcome Richard's question and would encourage you, Richard, to feed that back in through your team structures as part of that conversation.
Last comment is from Richard, and he says that as the team managing the equipment for testing in these areas, we're also massively unstaffed, and there is no recognition of the amount of work it takes to run these services, let alone any help with governance, as often these are basic issues surrounding identifying patients correctly on devices when samples are run. So thank you very much for the comments, and I'm going to ask Robin to respond.
Yeah, and thank you very much for the question. And what I urge you to do is thank you very much for the suggestion, and it's worth having a conversation with Lisa Vipon first, and then through to the care group leadership. So that'd be Rich or Gemma to get into the micro detail of that specific issue, and they could pick that up and support you with that.
That's all our questions today. So thank you very much.
Thank you. I really do welcome the questions and comments from members of our staff, members of the public. It really makes a difference to us, and you're what we're all here for. And so your ears and your eyes on what we're doing are really valued. So I very much appreciate your time in joining us and in proposing some questions to us. We then move on to the evaluation reflection of the effectiveness of our meeting. What went well? How could we have done better? Are we being consistent with our board etiquette? Are we considering health inequalities? Are we thinking about communication of what we discussed here? And are we contributing to patient safety? So those are our questions that we ask ourselves to reflect on in terms of today's board meeting. Alison.
On what went well for me, I think there's two areas. It certainly felt as an exec that there was a lot of challenge from non-exec directors on assurance, and on the second thing that I think went well today, I think every single item we were thinking about health inequalities or inequalities. So I think that was also a very positive thing from the board today. Thank you.
Thank you, Alison. Ian?
Yeah, I think we ran really well to time. We seemed quite disciplined. I think we had good, challenging conversations, and I agree with Alison, not just from non-exec challenge, but actually exec to exec challenge as well, which is equally as important. The bit I think we particularly did well on is we spent a good chunk of time on the equality, diversity, inclusion report and some of the important topics within that, which I think in my brief time on our board, we don't always spend as much time on that as we do on some of the other safety and financial matters and other aspects. So I thought that was good too.
Very much, Ian. Spell? Alison?
I think for me, the experiment around presenting the committee papers for me, I think felt quite successful. It was certainly concise. I have a slight worry that did that allow sufficient time for the board to really consider the plethora of reports. However, for me, it felt as though we were able to cover much more territory and get to the depth where we needed to. So for me, I thought that was a good change, and extremely well chaired in terms of timing.
Well, that's everybody. Thanks to everybody for that. Usman.
So yes, I really liked having the summaries in each of the assurance reports. One thing that I wonder if we could do better is the triangulation between some of the common threads between those reports. So there were, threads coming through in a few of them, and I know the chairs meet together before this board meeting, I believe, and I wonder whether if we could have almost a summary of some of those areas that are overlapping between all of the committees, that could be really helpful, and fuel the discussion, because otherwise you're not really sure which area of the report to bring up an issue in, and it may have already been discussed.
I know that's helpful, and we do have a note of those meetings, so there'll be no reason why that note couldn't be circulated to board members. Yeah, good suggestion. Thank you. Well, considering that we've managed today's meeting at a time when I know our hospital is extremely challenged, more than extremely, really, I think thank you very much for everybody's attention and attendance. And I think with quite a daunting agenda, it has been good to feel we have had the discussion where we've needed to. So I really appreciate that. And I'll perhaps let folk know when the next meeting in public is, which I believe is the 7th of November. We will, the board will now take a short break before we reconvene to pick up the matters which are discussed in committee. May I suggest that instead of reconvening at 3, we reconvene at 2:45? Would that be all right? Everybody? Great. Can I thank everybody very much, and very particularly to members of the public and staff for your contributions and your presence. Thank you very much indeed.